Boydar, Croeso Cyfarfod Board Iechyd. On behalf of the board, may I welcome you all to today's meeting of the Health Board, which is again being live streamed to enable members of the public to observe the meeting in real time. Members are also welcome to contribute in the language of their choice, as we have Larry here to provide Welsh to English translation. Larry's already explained to members how the translation system works. So I have apologies received from Nikki Callow, Gaynor Thomason, Adrian Thomas, Dunnan Roberts, and Jackie Hughes. Are there any apologies that I've missed? Nope. Nikki, you're here. You joined us. Thank you. Declarations of interest on the current agenda. Are there any declarations of interest that anybody wishes to notify? No. Okay, I will move us on again then. Minutes of the last meeting of the 26th of May. John Glanders, I think you've got a correction to suggest, first of all. Is that correct?
Yes. Yeah, it's under 22/108.3, second line. We seem to be missing something on that line. It doesn't quite read as a formal sentence there. It was noted that there was a number of areas that required urgent attention and that we're receiving this. It's just a clarification on the grammatical sense there. Thanks.
Okay, you're happy, John, for me to address that with Philippa outside?
Yeah, that's fine, yeah.
Thank you. Thanks for highlighting that. John Cunliffe, I think you had a question about the minutes too. You're on mute, John.
Thank you. Sorry about that. Yes, 22.114.9 on page 8. There's a set of bullet points which are referenced in the action log, but there's no action noted in the minutes. It's only a minor one, but it just needs to be noted in the minutes that there's actions there.
Okay, thank you. We'll pick that up too, John. Thanks. So, subject to those corrections, are colleagues happy to approve the accuracy of the minute?
Yes.
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 Okay, thank you. We'll then turn ourselves to the action log, and I'll make comments about the accuracy of this later in my introduction. But in the meantime, I will run us through the actions. So the first is shown as completed and relates to the operational plan monitoring progress report. That is on the agenda, and we will come to that shortly. Nick, Vascular is shown as completed in terms of the discrete action, and there is an update on the agenda. So I suggest also that we take that there if you're happy to do so.
Thank you, Chair.
Yeah. Can you ensure you pick that up, though, Nick, when we speak about the item on the agenda for me?
I will.
Molly, review of meeting effectiveness. I don't see how this can be on track because the target date set was October and the meeting seems to have been postponed and will be arranged as soon as possible. What's the latest, please?
So thank you, Chair. So based on the update we had when we met about board development, I think there's two key actions we can incorporate into that. So one is that we're addressing duplication, which was raised last year around the cycles of business of committees and board and having duplicated items going back and forth. So we've started addressing that as part of the review of the cycle of business, and all of those documents will be ready at the next set of committee meetings for approval, and also for the board in September. And then the next aspect, which was about some of the feedback that was quite material in relation to the papers, we're proposing that we put that into our board development cycle and ensure that it's all integrated. And we've met to discuss the timescales of when the board development program will commence, and that's kind of in line with the October deadline. But most of the material work will happen before that.
And we'll come on to, Molly, some other issues about the papers. So we'll close that action from here, but I'll highlight some other things when we come on to my introduction, as I say. Nick, the next report, the next action was with you. It's shown as progressing. The final report has now been published and will shortly be shared. Has that now been shared?
It will be shared initially in the private part of the board meeting, Mark, and then published publicly thereafter, subject to our meeting this afternoon.
Okay, so can we agree that we're anticipating we're going to close that action at the close of today, Nick, unless there's an issue that arises we're not anticipating?
Indeed, thank you, Chair.
And then, Sue, there is an action which again cannot be judged to be on track in my view, because it dates back to the March meeting and was about wall clerk capacity and support. What is the position with that action at 5?
So the information has been circulated, Chair, and the update provided, just not included in the update report. Just to be clear, the action arose from a discussion around providing additional capacity on wards to answer phones.
Yeah.
So the ward clerk was one option in that. That wasn't the full action, but we have provided the information that should have been circulated to board colleagues. So hopefully that action is now closed.
Have colleagues seen that information? Stony silence. I don't recall it, Sue, but I receive a lot of things like you. So could you possibly recirculate it, please, and then we'll close it for the moment.
Yes, I'll ask Philip to resend. Thank you.
Thank you. 6 is now done. I did it this week. Again, there was a delay that we need to avoid in the future. The next actions are shown as completed. And in terms of 10, Joe, I assume that at the moment, at least, you've been satisfied with the IT that you are equipped with at Carlton Court, and I can close that now, can I? Joe?
I do hope so. Delan, who's on leave today, has undertaken a thorough review and provided us with a report back. There were no one issue contributing to the challenges at Carlton Court, but a series of interventions have been put in place with regard to both our systems and our software. So hopefully there will be fewer issues of connectivity that are within our control to manage. I do think that it's closed, but obviously we will need to keep the matter under review. Thank you. Okay,
thanks. Thank you. 12, the operating model is on the agenda today and will be in September. We can close that particular action. There are other actions listed below that we'll come on to, I suggest, in the OM update when we get there. If colleagues don't feel they get sufficient assurance on any of those points, I feel sure they'll highlight it in the discussion later. 18, Jill, there is no update from you.
If I may, Chairman, I'm sorry if this hasn't been circulated. I'll ask Molly to recirculate it following the meeting. But following that deep dive in diagnostics, there was a further assessment of waiting times in endoscopy, CT and MRI, because they're the most challenged diagnostic services. As a consequence of that, we are doing some significant work looking at the demand and capacity to establish what actions are needed. We've got a particular emphasis on cancer diagnostic waiting times, and that is also being followed through on the newly formed Cancer Strategy Partnership Group. The endoscopy group have an action plan in place, and diagnostics have reviewed their activity, and we do have insourcing and outsourcing programs in place, but these continue to be monitored in line with our pathways for planned care.
Okay, and then I'll take us through. I know John's got his hand up, but I'll come back to John. 21, the quality highlight report was also not updated by way of action. Anybody can speak to that? So the action was for Matt to share the timescales following the review of the acute intervention team. Matt.
Thank you, Mr. Chairman. I am here for the patient story, so I can update on that if this is okay. I can confirm that the review has been completed. A baseline assessment of the AIT teams has been completed, so we now have a clear understanding of the provision across the 3 sites. That's led to the development of a task and finish group that has been led by senior nursing colleagues under the leadership of Mandy Jones, Deputy Director of Nursing. And over the next 3 months or so, there'll be work done to standardise the operational standards, the competency framework, and the training packages in place. So I think if the board's happy, I'd recommend we close that action.
Okay, thanks, Matt. Lucy, did you want to come in on that action?
Yes, please. Thank you, Chair. Just wanted to check with Matt. Has that review included the issues recently highlighted at Ysbyty Gwynedd in relation to the redeployment on occasions of the acute intervention team, please?
Lucy, so I'd have to check to be certain about that. My understanding is that the funding and establishment is now in place for all of those teams. I think there are issues around recruitment as part of the ongoing cycle of recruitment rather than any particular issue. I'd maybe have to just check or perhaps defer to colleagues on that particular point. I'm not directly involved in that.
Okay, thank you. Can I suggest that I pick this up with you outside of the meeting then, just to make sure, because I've had concerns raised.
Of course, absolutely, yeah.
Thank you.
Sue G's also got a hand up. Sue, did you want to come in on that?
Yes, please, if that's okay. So colleagues will be aware that Gaynor, Thomason and I have been leading a review of concerns expressed by colleagues within the workforce in Ysbyty Gwynedd. One of those concerns relates to being redeployed and moved on a regular basis. That review has been undertaken, supported by an independent colleague as well. Gaynor and I have received the report and we are reviewing the report through this week, and then we'll be confirming what action is appropriate to move forward, both to address the concerns that have been raised by the team in Ysbyty Gwynedd, but also to assess whether the similar concerns or issues are occurring on the other sites. So that is in hand, and those concerns have been raised through members of the Senate, but also through our own Speak Out Safely process, and are being taken very seriously. Thank you.
Thanks, Sue. Lucy?
Thank you, Sue. Can I just please ask that information is shared with me, because the concerns were raised directly with me as chair of QSE committee, and the executive team are aware of that, and yet I've had no update on any of the work that you've just described. So please, can that information be shared with me? Thank you.
So I can share it, Lucy. I will need to be mindful of, subject to when we review it. More than happy to share it, but we'll need to be mindful of any due process that needs to take place after that, and your role potentially as vice chair. But we, of course, we'll provide you with an update in terms of where we are, what it covers over the next week. Thank you.
Okay, thanks very much. So we'll close that action off the agenda, and I'll leave Lucy and Sue Green to follow up on the point that's just been raised. John C.
Thanks, Mark. It was going back to items 13 through 17. It's really sort of not a concern that they all refer to a report on the agenda, but I think it doesn't help us if there's no direct reference to where in the report that the actual actions are addressed. And I'm not sure in all cases that they have been. When we get to report, obviously we can go through it, but if you take item 13, for an example, looking for a timeline, I'm not sure the report gives us clarity of the timeline. So it's really a plea for responses to actions to, if there's a number of detailed actions that refer to a report, we need signposting into the report where the action is actually dealt with.
We do, and I agree, and we will follow that up, John. Thank you. Right, so I will move us on then to the patient story. Angela, is it you who are fielding this?
It's Matt who's going to be delivering it for me this morning.
Okay.
Thank you.
Okay. Angela, while you're there, I should say welcome. I apologise, I should have said it at the start, but we did have a catch up yesterday. Welcome as our new Executive Director of Nursing. And
thank you very much.
Look forward to working with you. Thank you. Matt.
Thank you, Mr. Chairman. I will now play the patient story, and then afterwards I'll just say a few words if that's okay. And I know Gareth would also like to come in.
Okay, thank you.
I'm Claire Jones. I'm the therapy lead for the long COVID service for BCU. I'm a physiotherapist by background. I started working with the service in summer last year, 2021, where we were working with patients with lived experience of long COVID to help us to develop the pathways for people with long COVID in North Wales, to make sure that they were getting the support that they needed and that we were going to be developing a service that was worthwhile and meaningful for the patients. The purpose of the service in the first instance is to provide a really comprehensive, what we call biopsychosocial assessment. So that's a really holistic assessment of the patient's concerns and needs, what symptoms are they having, and one of the really first important things to do is rule out other causes of their symptoms. Because the symptoms of long COVID are so far-ranging and non-specific, we've got to make sure that there's nothing more serious going on.
March 20 was when we went into lockdown. I got COVID over Christmas. After sort of 6-7 months, I slowly recovered enough to go back to work, but then found I got tired quick. I felt very weak. If I go up an incline, my breathing intensifies and the legs just go to jelly. I've had intense chest pains. I've had panic attacks, severe panic attacks. I'm probably only at 50% of how I was pre-COVID.
I got diagnosed with long COVID in February. Physically, it's affected my strength, mobility, pain. I get brain zaps. Brain zaps are awful. It's like a zinging noise in your head. And now I can't think straight.
With long COVID, it was continuous breathing problems, and I suffer with chronic fatigue. The last 6 months I've had to start using a cane to support me. I get a lot of brain fog, they call it. The wife's got to be with me when I have a bath. She's got to assist me with cooking in case I forget things, because I just walk away and forget what I was doing. My memory's totally gone, and I used to have a good memory.
I contracted COVID December 2020. Coming back from that has never really sort of got back to what it was before. I've known that I've not felt as I did before, and I know what the symptoms are, and you know when I get flare-ups, what that's like, and it's been quite difficult sometimes to access any support for that.
One of the elements that was really important to the patients that had long COVID was that they had an option for self-referral in order to access the service. Some of our patients had been suffering with symptoms of long COVID and struggling for many months before the service was launched. And they've had to have lots of GP appointments. Sometimes that has been difficult, particularly during the pandemic. And they felt very much so that it would be easier for them to access services and not have to bother their GP to be able to make that self-referral.
It's just the ignorance. It upsets you when people don't appreciate what you've gone through, what you're still going through. You go around in circles, they say you're fine, there's nothing wrong with you, but you know your own body, you're not fine. If you contact the GP, you can't get through 99% of the time. When you do get through, they don't understand what's wrong.
I've been referred to physio by my GP, but the physio that I have does it over the phone, doesn't understand long COVID, doesn't understand my limitations, and when I say to him over the phone, I can't physically do that, he then gets frustrated with me, but he's not looking at me and my, limitations. So I feel then I'm failing.
So patients are seen by one of the advanced practitioners in a face-to-face clinic, and we're able to provide that full assessment, any diagnostics that are required, and if patients do need referring on to any of the specialist services, then we're able to provide that. And then A lot of patients might then be invited to our group sessions where we will look at some of these issues in a bit more detail. Patients are attending every other week for 6 sessions at the moment. We've had 2 cohorts so far that are just coming towards the end of their block of sessions. And so far the feedback has been really positive. So we're running groups throughout North Wales, trying to provide this care as close to home as possible with the staff that we do have. We usually give them some helpful things to go away with, things, ways to deal with their fatigue, looking at their breathing pattern. Is there anything we can do to help with that? It's a great opportunity for peer support and to delve a little bit deeper really into the overall effect that this is having on some of the patients. And one of the really big things that patients tell us is that they feel that their symptoms are validated, because for quite a long time I think people feel that they're not believed, that they should just be getting on with things, and it's quite isolating for patients.
When I came here, for me it's like, oh my God, somebody actually believes what we're going through, somebody actually can understand what we're going through, and on the back of that hopefully will help us get through this.
You need all the help you can get, and just like I say, coming to this it helps tremendously, and mentally as well. It's not just physically recovering, it's mentally recovering.
Yeah, I just think something like this has provided an opportunity that's been a long time coming, but it's absolutely invaluable. It's that acknowledgement that what you're trying to say and what you're trying to share is not a fabrication or an imagination. This is something real.
So having spoken to some other services in England and Wales, it seems that I think we're the only long COVID service that are offering a self-referral option at the moment. And we're now starting to get quite a lot of interest from other services to see how we've managed to implement that and how it's worked, what have been the pitfalls and the benefits really. We are over 900 referrals into the service since December 2021, which I think just shows the impact that long COVID is having on the population in North Wales.
Without their help, we'd be on our own. We'd have nobody to help us. We haven't got a voice at the moment. They deserve all the help and recognition they get, because they're only learning off us and we're learning off them. Without them, there will never be a better life for any of us.
Thank you, board members. That concludes the patient story. I'd like to just, as usual, extend our gratitude to the patient and the staff members who helped in pulling together the story. The paper that accompanies the board meeting pack gives a summary of the service, but also particularly what I would draw board members' attention to is the significant work that's been gone into co-design and co-produce this service with patients who suffer from long COVID across North Wales, and describes some of the interventions and the work that's taken place in that regard, as well as some of the longer term plans to increase the engagement with patients as part of the continued development of the service. And the service will be bringing on board some engagement officers to work directly with them on that regard. Although I can't say too much at the moment because of embargo, that I think I'm hoping to be in a position to share some positive news with the board perhaps in the next week or so about some national recognition for this team as well. As was said in the video, this I think is a very innovative service, and the amount of co-production and co-design that's gone in has really developed, I think, a very positive service for patients. And we are sharing that best practice nationally across Wales and wider into England. I'll happily take any questions, and I'm conscious Gareth may also want to contribute or pick up some of the questions as well as the exec lead.
Gareth, do you want to comment?
Yes, please, if that's okay, Chair. I'll confine myself just to a couple of comments. Really, I wanted to really endorse all of what Matt has said, really, about what's been presented. I'd also highlight that although you've heard from Claire Jones, one of our senior clinicians who's been involved in the design and the delivery of this service, None of this would have been possible without some of the support of Matt's team as well, and the roles that he's created in his team. They've been invaluable, working with the clinicians and those with lived experience as well. There's a couple of aspects of real outputs, I think, that really bring this to life. One of them was mentioned in the video, which was the importance of self-referral in our pathway. That was a decision we took in North Wales, which diverged slightly from the model All Wales pathway, but we did that specifically because we co-produced and co-designed this with those with lived experience, and that was a very strong opinion they held, and one which we designed into our local pathway. The other output, which is not yet complete but is ongoing, is work to develop what will be the first outcome star in the United Kingdom for long COVID. Outcome stars, if you're not familiar with them, are examples of PROMs, patient reported outcome measures, validated evidence-based tools that allow people to measure really their progress in regards to their condition, and are often self-completed. That's work in progress, but that is being done again with in collaboration between clinical staff and service users and those with lived experience, and I look forward to that work coming forward. So that's all I wanted to say, Mark. I'm more than happy with Matt to take any questions about that.
Right, okay, I've got 3 hands raised. Can I ask colleagues to be succinct, please, conscious of the time? John G first.
Yeah, 2 specifics, if I may. One in particular in relation to numbers and access. 900 coming in a relatively short period of time. Can we have some indication with regard to the length of time that people actually need to wait? Because clearly it looks like an extremely good service. And the other element is, if we've got that number who have come in a short period of time, are we actually committing sufficient resources? And then just the final point, I note that we don't have this service available for children and young people. They have to be referred into Alder Hey. And I just wonder if we are looking to develop anything in North Wales for children and young people. Thank you, Chair.
If it's okay, Chair, I will answer that. Thank you, John, for those questions. Yeah, number of referrals now is up at 1,089. So in terms of waiting times, the average waiting time at the moment is around about 104 days, which I think in old money is about 15 weeks. But being an average, of course, there are people who are less than that, but there are people who are longer than that. The longest wait is around about 30 weeks at the moment. I do urge some caution with the use of the data at the moment, because as you highlighted, it is a new service. So we don't have, I think, enough data points yet to really draw any trends out of that. But month by month, we are learning about that. As you'd expect with a new service, there was quite a bulge at the beginning between December and February of referrals, and since then, month on month, they've been gradually declining. It's fair to say that at the moment, demand is still higher than the capacity we have in the service. We've taken some time to be able to recruit into the service in part because posts were initially went out on a fixed term basis. They weren't recurrent because the money we have for the long COVID service at the moment is non-recurrent in nature. We have subsequently committed a number of posts on a recurrent basis, and recruitment has been healthier, and we are getting close now to having a full team. So therefore our capacity is improving. In terms of children's services, John, you're right. Referrals have up until June gone to Alder Hey, which was the specialist pathway for children. That service is now no longer available. So there are local and national, as in Welsh, discussions going on about the best way to deal with children who present with long COVID. Thank you.
Thanks, Gareth. Thanks, John. Cheryl?
Thank you very much, Chair. Thanks, Matt and Gareth. John asked my question about the children and young people. My other question is, what sort of support are we offering to carers of our patients with long COVID, and do they have representation on the partnership group? Thank you very much.
Thanks, Cheryl. Gareth?
Yes, thank you. Yes, they are involved in terms of the partnership group. They are a key part of the cohort of people who have designed and are continuing to design and influence the pathway. In terms of support, there is a range of material available both through our web pages, but also through national web pages, Cheryl, for people who are both living with long COVID, but also supporting those as well. It is an area, though, I would say locally, we still have a little bit more work to do on, and our engagement group will, I think, be very useful in developing those resources further.
Excellent, thank you.
Thanks both. And finally, John C.
Thanks, Mark. Thanks, Gareth. I commend the service. I just wanted to ask how we would get assurance that the service design is correct, in that we heard that it was difficult getting GP access if somebody potentially has got long COVID. So if you've done co-design and co-production, how have you identified people to do that with?
Thank you, John. I'm not quite sure I understand the question. Do you mind repeating it?
If no, it was stressed that the service has been designed through co-production and involvement of people with lived experience. But if you can't, how have you identified those people to do that with? Because we heard in the video that people have difficulty getting access or support from GPs. So you may not have been able to use that route to identify people. So how do we get assurance that you've actually pulled together enough people to be able to design the service, particularly as you're now seeing an increase in the number of people who are self-referring?
Okay, thank you, John. I understand that now. So I'm going to let Matt come in because he's got his hat up, because he was more involved, his team were more involved with the actual identification of the cohort.
Right. Can I just repeat? Can we keep this succinct, please? We are already running behind. We have a long day ahead of us. Matt, then Linda.
Thank you, Chair, and I'll be incredibly succinct if that's okay. I think the comment, John, around access was around patients being able to access a range of services, and the long COVID service is designed to provide people with a kind of single route in rather than having to navigate through multiple services. To engage, we worked far and wide to look at patients who are suffering with long COVID symptoms. We didn't just have one cohort, we've had an extensive cohort of people that we've worked with at various points through the development of the service. The lived experience group that's mentioned, the lived experience partners that we have, we've got a wide network of those, and that's an ongoing process. In terms of measuring outcomes, there's a continual process to gather both patient experience measures, so people's experience of the service, but also, as Gareth said, the development of patient outcome measures as well, so that we can gather both the experience and the outcome measures. And again, that's part of an ongoing process. Promotion of the service, I think, answers some of your question, John. So we have worked very hard again in the last month to promote this service across all avenues, including GPs, so that there's a wide understanding of the availability and the ability to self-refer into the service.
Thank you. And finally, Linda. Diolch, Linda.
Diolch yn fawr. Ga I just gofyn I Gareth, ydy'r gwasanaeth yma ar gael yn y Gymraeg o gwbl? Diolch.
Thank you, Linda. We have, I think, at least one Welsh speaker, but I would like to go back and check that to give you accurate information, if that's okay with you.
Iawn, diolch.
It's an important question, isn't it, Gareth? Yes, if you could, please, outside the meeting. And if there's concern, Linda, can you let us know?
Iawn, diolch.
Gareth, Matt, there's a question posed in the chat bar by John. Could one of you respond to that, please, out with the meeting?
Of course, yeah, I'll make contact with John, Mr. Chairman.
Okay, thank you. Thanks, and really commendable service. Much to commend in terms of the experiences of patients as they described it, and much good work that's gone on. So let's hope that we can build on it in keeping with the questions and the responses that have been posed, which clearly ought to be our ambition. Thank you, Matt. Thank you, Gareth. Keep up the good work with your team, please. So we move on then to public forum questions. There are none that have been received. I have, however, asked Philippa to check the process because I'm surprised given the nature of the number of items on the agenda, but we'll pick that up outside. So I then come to my report. And as you'll recall, at the meeting in May, given other matters that we needed to focus upon, I didn't do my usual chair's report in terms of chair's actions. So the list will seem long, but you need to take account of that fact in receiving the list of chair's actions. And they related to flow cytometry contract award, 3 high value claims, the lease of rooms for neurodevelopment services at Park Benai, the lease of extension for CAMS team at the Optic Centre, endoscopy contract extension, temporary building lease for prehabilitation services in the East, regional treatment centres phase 1, which was a direct award approval, contract requests to novate the general dental services, TAO and exemplar lease, neurodevelopment contract, a tender of all Wales framework agreement for the provision of insourcing and outsourcing of clinical, surgical and diagnostic procedures, and a Wrexham imaging tender award. And just to confirm, of course, I do receive advice from the board secretary about the suitability of chair's actions, and others are involved in the decision making as well. Okay, I'm now going to turn to some more substantive items in terms of my update. I previously clearly indicated in this forum that the late or incomplete publication of papers for board and committee meetings, save in very exceptional circumstances, is unacceptable and impedes the board in exercising its governance and assurance role and weakens the opportunity for public scrutiny. Yet this has happened again, along with the fact that the action plan has either not been updated or inadequately so, as we was highlighted earlier on in the discussion on the action plan from the last meeting and previous meeting. Both matters which members will know I'm far from happy about. These are simple and basic expectations of an executive team and an organisation, and a failure to meet them is, in my mind, indefensible. Moreover, the quality of some of the papers, for example, the performance report and the finance report, are of such quality as to offer no or little assurance. Notably, these 2 papers are not accompanied by the required report template, which requires a grading on the assurance level, which in the circumstances no doubt would have led to further challenge for myself in terms of the assurance being provided, I'm sure by board colleagues. I clearly laid out these and other concerns to the Chief Executive last night, and which members will have seen. I have to say I'm also concerned that the executive team have judged the reports I refer to be acceptable from their perspective in running the organisation. And I expect the CEO to offer an explanation and proposed action in our update, along with the board secretary if necessary, when we come to Joe's update. In terms of the management today, we have a public meeting, a private meeting and a workshop. Whilst recognising the papers I have highlighted, indeed some other matters will require and generate significant discussion, I want to stress, please, the need for the papers to be accepted as read, the presenters to focus on key matters they feel they need to highlight, and for all contributions to be direct and succinct. Were this to prove not to be the case, I'm likely to intervene in the interest of good governance and good conduct of the business today, so please bear that in mind. The agenda and discussion today will also capture a number of challenging and concerning matters, including the following. The fact that despite positive feedback received from officials, the 3-year integrated medium-term plan submitted has been accepted as an annual plan only, a matter that we will discuss when we talk about the IMTP later. The determination that our accounts for 2021-22 are to be qualified, a serious matter which has been subject to significant examination by the Audit Committee, and a matter that the CEO will address in her opening, and the Chair of the Audit Committee refers to in his assurance report. Vascular and the range of challenges that continue to persist and which require solution. Also, the decision by HIW to classify the whole YGC site as a service of significant concern, the improvement plan in respect of which has been subject to much scrutiny through Cabinet, which I stood up for the purpose. And finally, discrete services and areas of performance, which have been the subject of exchanges between the Minister and myself, and which include urology, ophthalmology and vascular. So we have much of importance to discuss today. As I've said, I ask that you bear this in mind as we move through the agendas that I've laid before us. Thank you very much. Joe, over to you.
Thank you very much. I will take my Chief Executive Officer's report as read. I would like to highlight a number of points, though, if I may. With regard to improvement activities at YGC, but not exclusively so, we have late last night received the draft support offer from Improvement Cymru following the joint diagnostic meeting held between IHI and Improvement Cymru on the 13th and 14th, followed up with Improvement Cymru on a meeting on the 27th of July. Essentially, the feedback from those sessions, in short, is that there is currently insufficient improvement capacity to support the current range of improvement efforts within the Health Board, despite acknowledging that we have one of the largest but one of the newest improvement teams in Wales. And there is insufficient capability across the organisation as a whole, ward managers, from ward managers upwards, to build and sustain improvement activity from the front line, from the floor. The combined IHI and Improvement Cymru programme is designed to strengthen awareness, capability and capacity at all levels of the organisation, including the board, with focused training interventions being proposed to be put in place for a period of time of up to 12 months. With regard to HIW, the chair and I met with the chief executive of HIW and some of his senior leadership team since the writing of this report. The chief executive of HIW did provide assurance that HIW find our relationships with them as an organisation positive, that they have confidence in our team, and that the responses we do make to HIW are seen to be of a good quality, which is reassuring to hear. Of course, more important is in making sure that we act, practically speaking, on HIW reports, and the HIW report on ED in YGC is due to be published next week, with actions in place within the emergency department at YGC in response to their findings. We're already seeing that ESDEC utilisation is increasing, which will further increase as we move to 7-day working within that service, starting on the 5th of this month of September. Triage times are improving, and we are much more confident around the presence of clinical staff in both adult and paediatric waiting areas. And significantly, we're seeking to implement GP direct referrals to the acute assessment unit, which will enable patients to be treated in a slightly different way. You referred, Mr. Chair, to the matter of the final accounts as referenced later on in the agenda, and in both the Chair's assurance report for the Audit Committee and in the Finance report. The audit of our accounts is ongoing, while Audit Wales finalise further quality assurance check on the accounts. Notwithstanding that, as you've already said, our accounts will be qualified. As accountable officer, I have made a recommendation to the Audit Committee that our accounts are not to be reopened, and the Audit Committee at its meeting have accepted my accountable officer recommendation. There will be an opportunity to discuss these audit matters elsewhere on the agenda. Finally, to your point regarding quality of papers and associated governance issues, I acknowledge the points that you have made and the requirements to improve in this regard. In order to ensure that we are able to sustain an improvement, the board secretary and I have agreed a more robust standard operating procedure, which is designed to ensure more thorough oversight and a QA process of all papers going to board and committees and all associated action logs and minutes. This includes bringing forward our own internal paper deadlines significantly, oversight of all papers, not only by the executive director responsible for the quality of those papers, but also by the entire executive team, supported by a more extensive QA process within the office of the board secretary. I'm happy to take any questions. Thank you, Chair.
John Galanders.
Yeah, thank you, Joe, for that report and update. You have answered part of what I was going to be asking, but in particular, we're obviously having a great deal of external support being provided, either directly being employed by the board or as a consequence of Welsh Government's additional intervention. We've been in this position before where we've had lots of external support. Unfortunately, quite often that never becomes sustainable within the organisation. You've made reference to our own improvement unit, but the key question I would like to ask is, what level of assurance can you actually give to the board that once these additional external support leaves, because most of it will be time limited, that as a board we can have any level of assurance that we will have the knowledge and the expertise within our own structure to be able to sustain all of the necessary changes going forward? Thank you.
Thank you, John. I've committed as part of our cabinet responses to share details of the detailed interventions that Improvement Cymru, IHI, and indeed our own transformation team are due to provide. The approaches we're taking are evidence-based, and they have proven to be effective in other organisations. And of course, we are a large and complex organisation, and I think it's important for us to consider that our improvement work is never done. As new staff join us, we need to ensure that they are as familiar with our own improvement methodology, called locally the Betsy Way, as those staff who are with us now, who will be part and parcel of our training and development interventions. The approaches we already have in place see us using an approach called improvement fellows, so that individuals are invited to work on improvement projects. They're trained and developed in improvement methodologies for a period of time. They then return back to their own clinical job, taking those skills with them. This approach, taken with the approaches being recommended by IHI and Improvement Cymru, will together enable us to ensure that our staff have the skills to be able to undertake their intervention. And as we look at not only the operating model, but the SWORD later on in the agendas, the ethos around both of those documents is to create an environment that enables clinical staff to make changes as quickly and as effectively as they can without constantly being required through our governance processes to seek permission. We are using evidence-based methodologies. That puts us in the best possible place to ensure that these changes are sustained. Thank you.
Thanks, Joe. Cheryl.
Thank you very much for that, Joe. Two quick questions, please. My first one, can you assure me of the continued presence and oversight of senior leaders in YGC ED, given the grave concerns? I know we as IMs are continuing with unannounced visits to see how things are going, but I would really appreciate where we're up to with that. And my second question, I think it would be really helpful. You mentioned the Welsh Community Care Information System. I think it would be really helpful to have a paper on that. As you'll obviously know, there's been a huge amount of problems with this system in local authorities because they have had this first. And I think the risks around that can't be underestimated. It's a very, very poor system and has caused a huge amount of problems for local authorities. So those are my two. Thank you very much.
Apologies. On your second question first, note your request for a paper. We'll take that away and work through which is the appropriate governance route to take that update. On your first question, yes, I can provide assurance that there is senior presence within YGC ED. Colleagues will be aware that Gaynor is now based permanently in YGC and spends a significant amount of time within ED, and executive directors are continuing to formally and informally drop in. I have recently opened an invitation to the CHC to spend time with Gaynor in YGC ED, so she can talk through with them directly the improvement arrangements that we have in place. Thank you.
Thank you, Jo.
We're concerned to ensure oversight and support to the team, aren't we? All of us. Okay, Richard.
Up and down, Mark. Thank you, Jo, for your report. I have to say, well, it's not so much a question, it's more of an observation. I'm a little disappointed in the report as a document. It sets out to say it's going to give us an update on key issues impacting the organisation, but to be honest, I don't read it as going anywhere near doing that. It's effectively a list of meetings and discussions that have been had with precious little stated about the outcomes from those discussions and what's going to potentially change as a result. This should be an extremely important report. It should be a report on what are the issues that have been addressed since the last report, given that we are an organisation with many, many shortcomings and failings that we're trying to address, and what is being done to resolve those. And yes, I accept a lot of the stuff will be covered in other items on the agenda, but a report from the chief executive of an organisation that's missing the mark quite considerably in many respects, I thought should be a little more dynamic and incisive than this. And I just wonder if it's possible to adjust the template for future such reports. Thanks.
Thank you for your feedback, Richard. I'll certainly bear that in mind for future papers. Thank you.
Thanks both. John G, your camera is still on. So I'm going to move us on, if I may, in terms of that report, and we'll come on to the Mental Health Act item. And it is for information because it notes the ratifications that occurred in terms of approvals in line with the guidance. Are colleagues happy to note the report?
Yes.
Yes. Thank you. Okay, so we now move on to the first assurance paper, which is the clinical strategy, which, Nick, I think you're speaking to.
Thank you, Chair. It gives me great pleasure to bring the clinical services strategy to the board for consideration for approval. I believe this is an important step for the Health Board because it lays out how we plan to deliver care to the population that we serve. It's built on the views of our staff. It's built on the key documents, Living Healthier, Staying Well, Healthier Wales, and a national clinical framework, amongst many others. and it's also taking into account the feedback from a significant engagement process, which is still ongoing and is laid out in Appendix 4. For us, I really do think this is important because it lays out in writing and asks for approval for things that many of us take for granted, but we haven't actually agreed as a board. And if we approve it today, it's a tool whereby we measure our future business, consider our future investments, and as we look at the development of service, this is a rule book by which we can measure our future work. I perhaps draw your attention particularly to pages 25 and 26, which lay out the guiding principles, and then if it's okay, Chair, to take questions. The guiding principles lay out the fact that our work is person-centred and outcome-based. That we don't do this as an executive team, as staff members, but this is co-designed and owned with the population and with our partners. That we look not just at clinical outcomes, but we look further upstream. We look at population health and how we can reduce inequalities, which of course is in line with the ministerial priorities for this year. And it challenges us, amongst other things, to look at things in a transformative and an innovative way. It also lays out the fact that we are committed to our community hospitals, recognise the huge importance of primary care, where the vast majority of care on a day-by-day basis takes place with the patients that we serve. It confirms our commitments to our 3 acute hospitals and confirms that emergency care, as well as delivery of other services, will continue on those 3 sites. And it also commits to the regional treatment centres as a principle within our strategy in order to deliver, amongst other things, our planned care. Within this, then, also there's the importance of the North Wales Medical and Health Sciences School, our specialised services, and lays out some options for delivering future services across the Health Board, be they on a hub and spoke model, a networked model, or indeed challenging us to think, as I've already said, innovatively using digital solutions, because care in the future need not necessarily be provided face-to-face, where a digital solution is at least as good or sometimes perhaps even better. So Mark, I welcome questions, and I think the real test for us, if it is approved today, is that we don't just leave it on the shelf, but we use it as a living document that defines our business going forward. Diolch yn fawr. Thank you very much.
Diolch yn fawr. Nick and I agree entirely. So any observations, questions? Claire.
Diolch, Chair. Thanks, Nick. And it is a very ambitious document and strategy, which it needs to be. I think my point might sound quite small, but I think it's quite fundamental. In your presentation, then, you talked about the need for things to be person-centred and very outcome-based and focused. But if we have a look at page 5 in our clinical vision, I think maybe we're just using quite an old-fashioned phrase, but we're talking about wanting equality of opportunity for everybody, which will help people realise their full potential. And I would suggest that with all the work that's been going on in the Health Board over the last 12 months around the inverse care law, that perhaps a more appropriate phrase there might be around addressing inequality in health, rather than, because equality of opportunity doesn't necessarily lead to equality of outcome or addressing some of the very broad-based inequalities we know we've got across our communities. So it might seem like a smallish point, but I think it's quite important in terms of our overall approach around having a healthier population and addressing some of the big differences in life expectancy and healthy life expectancy. Thank you.
I don't think it's a small point at all. I think it's a really important point. Nick?
Thank you, Claire. And indeed, an important point. I suspect some of the language is a function of the many documents and guidance on which this is built, and the need to bring a consistency of language across those documents. But very happy to take that away, Mark, and to consider updating the document accordingly, because I think it is a very important point. Thank you.
Thanks, Nick. Nikki?
You're on mute, Nikki.
Thank you. So in the cover sheet for this strategy, it talks about the workforce implications as a result of implementing the recommendations, and it states that the IMTP will deal with those workforce implications. Given what the chair has said about the IMTP only being an annual plan, I'm concerned that there needs to be some consideration of both the clinical service strategy and the living healthier, staying well in terms of those workforce implications to ensure that we can actually deliver on these strategies. Now, it might be that that observation is best placed when we come onto the IMTP to see how we're going to handle the long-term planning, or it might be that you could sort of address some of your thinking now around how we would deliver that workforce implications through that are needed as part of this clinical service strategy.
Nick?
Thank you, Nikki. There is a clear interdependency between all of these documents, all of these strategies, and I fully accept that one on a standalone basis, there will always leave questions that need to be answered. I don't know whether colleagues would wish to come in around the people strategy and the IMTP, but I would suggest this is but a key foundation for further work going forward. And if we apply this to some of our historic work, then it's not this strategy is only being approved today. So it obviously points out some gaps in our previous, which is why it's so important. Thank you.
Thanks, Nick. So Sue, then Joe.
Thank you, Chair, and thanks, Nick. I think, so the reference to the IMTP, I take that point entirely. I think had it referenced the people strategy and plan, which is a 3-year strategy, which does align with this strategy and actually is enabled, they are mutually enabling, because we've often talked about the way in which we deliver our services has a direct impact on our workforce challenges and vice versa. So I think had this point referenced the people strategy and plan, it may have been a little bit more appropriate and wouldn't have then necessarily been impacted by the issue with the IMTP. Thank you.
Perhaps that needs to be considered moving forward.
Thank you.
It does. So can we agree that is going to be considered moving forward? Nick and Sue?
Yes, Chair.
Thank you. Joe's put her hand down. There's a comment in the chat bar, so I won't go to Joe. Cheryl.
Thank you very much, Chair. Thanks for this most welcome report, Nick, and all the work that you've put into this. I've got 2 questions, please. On page 7, you talk about providing as much healthcare in North Wales as possible. I take it we're still fully committed to using our partner areas, e.g. the Stoke Trauma Centre, Walton Hospital, Broadgreen, Alderhay, Gabowen. I take it that commitment, we are still using those centres of excellence. That was my first question. And my second one, on page 26, we talk about community hospitals. I would really welcome a look at the whole community hospital issue. We've seen throughout COVID the lack of beds and facilities, and I think we still have an untapped resource there that we could look at further developing. So those are my 2. Thank you very much.
Thank you, Cheryl. In regards to our commitments to services outside of North Wales, the principles, of course, talk about us bringing care as closer to home as possible, and where possible, care being delivered in primary care. So this strategy in no way changes our current relationship with our providers in North West England or elsewhere, but it does give us a blueprint to consider in the future whether any of those services might be brought home, and indeed whether services within our acute hospitals could potentially be provided in our community hospitals, and services in our community hospitals in primary care. So it gives us a structure with which to make those decisions in a consistent and fair way. In relation to the community hospitals, I think they are a jewel in our crown, and I think we sometimes perhaps can't always see the full potential. There are pockets of fantastic practice going on as we speak in all of our community hospitals. And again, this provides us a way to really consider how we can utilise those and how to utilise the community commitment and the value that they hold them in. Thank you.
Thank you, Nick. Most welcome there. Thank you.
Thank you. And Lucy, final word, well, apart from me, is yours.
Thanks very much. Yeah, I really welcome this clinical strategy as well, and particularly the pathway approach. I just wanted to ask about the pathway itself as part of its development. So the document talks about impact upon other services as the pathway is designed. It does refer to comorbidities, but will you also be weaving in, as part of any particular pathway for a condition or disease, how the patient being at the centre of this, how will their other conditions actually be affected by that pathway design? Because what we don't want is a single pathway for a patient when actually it then impacts upon other comorbidities, etc.
Thank you, Lucy, and I couldn't agree more. When I was working full-time clinically, it was always a frustration that one patient was receiving duplication sometimes of care, and dare I say even sometimes confusing care, because they were on different pathways. So we need that matrix of absolute governance and high quality pathways that we value and the patient understands, yet it's at the same time making sure that we're not duplicating or even worse, confusing patients and our resources. Thank you, Lucy.
Thanks, Nick, and thanks again for all the work that has gone into getting us to this place, which has taken some time as an organisation, but finally we've got to a place that we can all recognise and celebrate. Can I just confirm, Nick, the sense of clinical engagement that exists in terms of arriving at this strategy in the first place, and the ability for us to engage with and take this forward with the clinical medical workforce, please?
Thank you, Chair. The Clinical Senate was set up in the Health Board for the very purpose of ensuring clinical engagement with this. I didn't want us purely to be talking to the same people that we always talk to, but to reach out further, both geographically across specialties and crucially between professions. So there was wide clinical engagement, Chair. I will be completely honest and say many of the workshops that were planned during November and December didn't take place because of Omicron at the time, and I do feel slightly uncomfortable that the Teams events were never quite as successful ensuring engagement as have we been able to have face-to-face workshops. But there was a very genuine clinical engagement. The proof of the pudding, of course, as ever, Chair, will be now we start to take this, if it's approved today, and actually work with our clinical teams to make it a live document that informs what we do on a day-to-day basis. Thank you.
Okay, and then finally from me, before I move to approval, can we agree that there'll be an update on the development of the clinical services plan before we get to the development of the IMTP, the timeline for which we're going to discuss later anyway, but some sort of interim update, given the importance of this document, Nick, perhaps towards the middle or end of the autumn would be appreciated.
I'm very happy to do that, Chair. We've already suggested in the cover sheet that we bring back an update on the engagement in September, and perhaps that might be, with your approval, a time to do that.
Yeah, okay, it is with my approval. That'd be helpful, Nick. So are colleagues happy to approve this important document?
Yes.
Yes.
Thank you. Thanks again, Nick. So I will move us on again. So we're on to the Living Healthy, Staying Well refresh. I think it's actually Living Healthier, but anyway, that's what it says on your paper too, Chris. I'm glad for that, because the agenda is incorrect. But anyway, over to you.
Thank you, Chair. As you said, I'll take the report as having been read, but just for colleagues' information, because Living Healthy, Staying Well commenced before some of us worked in the Health Board. It was and remains our overarching strategy, and was put into place in 2018, and we committed after 3 years to do a refresh of that, and that refresh occurred in 2021 into 22. The feedback is within the report, and as you will appreciate, there is a range of different approaches taken for that feedback, in part reflecting the COVID times in which that occurred. Partners and staff were involved, as well as the public. And the broad view that comes through very clearly is that this remains strategically appropriate for us, alongside our planning principles and alongside the clinical services strategy, as has just been discussed. I will just pick out some of the key areas where concerns were raised. You'll see through the report a number of observations in terms of how our aspirations have not necessarily resulted in anything but delivery, and many of those comments are qualified by the fact that the process was undertaken during COVID times. Likewise, as you would also expect, as related to COVID, waiting times also came up, both in terms of COVID and more generally. The last point that I think does come through in the feedback is in terms of the risk to health inequalities through the risk of unintended consequences, and particularly the travel for subspecialised care comes through in the report. What the report, I think, feedback does say is that there is a general acceptance of at least the reasons and the rationale for needing to travel for subspecialised care, and these are conversations we have had in a number of different arenas, a number of different clinical areas over a number of years now. But of course, what people are feeding back is their concerns of the practical issues related to the travel. So principally understand it, but what about the practicalities? And there is some work that we can do as a consequence to better unpack some of that feedback. The last point I would make then is that moving forwards, this feedback has already influenced our IMTP and general planning. It's already influenced the development of the clinical services strategy that we have just discussed, and we will of course continue this in terms of our planning and in terms of maintaining the dialogue with the public of North Wales.
Yeah, Chris, any comments? John and then Claire.
Thank you, Chris, for this. It's just a general observation, really, in terms of engagement. We've just heard from the clinical strategy around engagement there. We have engagement with IMTP. I suppose it's really a case of strategically, are we not in a position as a board to look at singular engagement? So we're actually trying to pick up all of these things, because from a patient point of view, they don't know the difference. All we're looking to do is improve the outcomes for the individual patients. But by consulting with them quite often on a variety of topics, gets them totally disengaged. And the other particular point around the data gathered from engagement, do we actually do any demographics analysis to ensure that it is statistically accurate with regard to the population across North Wales? Thanks.
Thank you, John. Two very good points. On the first point, since commencing this work, we have Helen with us now, and part of the remit for Helen is to do exactly as you've mentioned, in terms of that cohesive approach to our engagement and communication. So absolutely, we should move that forward. In terms of the demographics, you will see in the report that some attempt has been taken to be as broad as possible in terms of collecting feedback on living healthy, staying well, within some of the limitations I referred to from COVID. Whilst we have a report here in terms of the refresh, those conversations will continue and should continue, and we're always striving to try and get into some communities that may otherwise be less well represented in the feedback. So I don't think that job is ever complete. Well, a solid point that we need to take away and continue to reflect upon, but we are making efforts to pick up those communities.
Okay, so Joe wants to come in, so I'll come to Joe now. Joe, in coming to you, or indeed Chris, there's reference in the cover report to risk management over the delivery of the strategic goals and the connection with the executive delivery groups. Can someone give an update on where we are with the executive delivery groups and whether they're all in place, please?
Thank you, Chair. Would it be okay to cover the executive delivery groups in the update on the operating model? Because I think it connects well in that part of the agenda, please.
Sure. Yeah. Okay.
Lovely. Thank you. John, thank you for your really helpful observations. As Chris mentioned, Helen is indeed working on our engagement strategy. Apologies, she's on holiday today. Really happy to connect you with her whilst this work is in development, so you can influence the shape and feel of our engagement strategy. Of course, you're right. We should seek to be as consistent with our engagement, and I'll perhaps contact you separately to talk about some of the emerging conversations we're having with regard to children and young people's engagement, which would be a subject close to both your and Cheryl's heart. Thank you.
Thanks, Joe. Claire.
Thanks, Chair. A similar point in some ways to John. 300 people responded to the consultation, and I accept we were in a COVID time, but out of our 700,000 population, we'd need even 7,000 people to respond for it to even be 1% of our population. So I think we do need to bear in mind that the numbers of people who did engage in the refresh were very, very small. And what's surprising is actually social media, we find often these days, is actually one of the best ways to engage younger people, and yet younger people's views were very low in terms of representation. So I guess I know Helen is working around the whole kind of engagement approach, so I wouldn't say kind of we got less engagement because we use social media because of the pandemic, because actually that probably is the route going forward to make sure we get very broad levels of engagement, whether that's through text or through Twitter, through TikTok, or whatever that needs to be. And actually younger people will tend to engage most if we do it that way. And I think we can really build on this because everyone's got an opinion about health services. It doesn't matter who you are, where you live and how old you are, you have a view around it. So similarly through the stakeholder reference group, we've had some discussions at our last meeting about the engagement strategy and approach, and we're really very happy as a group of representative organisations to help support that work within the Health Board.
Thanks, Claire. Chris?
Again, entirely agree. The 312 people were with regard to a specific online questionnaire. In addition to that, there was Twitter and social media used. I don't have the specific numbers for that. So the feedback is more great than the 312 people, but I actually do recognise the point that you're making, Claire, and fully support it. We'll take that away.
Thanks, Chris. So we are asked to receive the report, note the confirmation of the long-term goals and the actions being taken in response to the feedback. In addition to what's been discussed and agreed, are you happy to do that as board members? Yeah.
Yes.
Thank you. Thanks very much, and thanks for the observations and questions. That was really helpful. So I'm now going to take us the IMTP refresh, Chris, which is you too. Can you, in doing so, cover in perhaps more detail the point I made about the IMTP being accepted as an annual plan, the feedback that's been received, and also the issues and how we're going to respond to them, please?
Yes, thank you, Chair. So in the last few weeks, we have had feedback then from Welsh Government that the submitted 3-year IMTP has been accepted by them as an annual plan with a number of milestones that they want to see, which we have now captured within our internal processes so that we can address those accordingly. We have further meetings next week with Welsh Government to unpack some sort of more granular detail, but the preliminary feedback that we have been provided with is that given the challenges that we currently are facing, that is where our focus should be, and that some of those issues have arisen since the original submission of the IMTP. And on that basis, it will be more appropriate for us to focus in terms of that annual planning cycle. I would say that a number of other health boards are in a similar position to us as being unable to submit a 3-year IMTP that Welsh Government feel able to approve. My understanding is that of the health boards, 2 have IMTPs that have been accepted, both with a number of additional requirements, and that the remaining health boards have not been able to submit IMTPs or have been requested to work on an annual plan basis as we have. We have had feedback that has been positive, as well as the feedback in terms of some areas that we need to be particularly focused upon right here, right now. In terms of the feedback right here, right now, we have done some additional work in terms of our planned care profiling. There were concerns in our original IMTP in terms of our planned care profiling, and we've done work with the delivery unit to move that through. We have now got to a position where the delivery unit and ourselves are content with the planning process we will use for that going forwards, and are working that through now, board committee back through to this full board to put through the revised figures. In addition, of course, we've already touched upon Glenclwyd and the particular focus now that we are placing upon some of the challenges that Glenclwyd especially is experiencing. In terms of the positive feedback, Welsh Government has been absolutely clear in terms of the progress that we have made as an organisation in being able to submit a 3-year IMTP in the way that our planning processes are now more integrated than they have ever seen. And indeed, many of the other health boards have been pointed to our IMTP to take aspects of it. So it is a mixed position. It's a disappointing position given the amount of work that has been undertaken, but it does put us into a position now where we can refocus very specifically upon the immediate here and now. In saying that, my recommendation to the board would still be that the IMTP plan serves as well as our baseline planning and delivery document, and that we should still be striving to build on the medium-term planning approach alongside that immediate here and now. The plan does need that refresh, particularly to factor in some of the Glenclwyd elements that I've referred to. But doing that and maintaining medium-term planning alongside is absolutely consistent with a good planning approach. With regards to the refresh, we're currently doing some in-year refresh, profiling some of the priorities that are in this particular year, and that is to make sure that we're appropriately prioritising those challenges I've just referred to, and we'll report those back to board as soon as that has been completed. But alongside that, we're moving through the planning for 23 and 24, and the pack contains the outline timetable for that. As we brought the IMTP3, we did explain that this was a multi-year process from our planning team perspective, and that we would build upon it in the coming year. That's exactly what we are proposing to do here. We are looking to make more progress on the work that we did in 22-23, building upon even further that integration, building upon the clinical services strategy that we have just approved this morning, factoring in more prioritisation principles and value-based care, and how we work within our cluster partnerships and the emerging health communities. I think probably I should stop there, Chair, but happy to pick up any questions.
Thanks, Chris. John? C?
I will click the button properly. Thanks, Chris. You touched on it towards the end, but I think the thing that just crossed my mind, irrespective of what Welsh Government have done in terms of approval, as a board, we approve this as a 3-year plan. And it feels like, you know, we have a responsibility to take a strategic view of what we're doing and plan for the longer term. And so we should continue with that 3-year plan and adjust it and adapt it as we go forward based on new information. So if we've got issues that have come out, which we know we have, and we've got concerns, the plan should be adapted accordingly. But it felt a bit like that the paper was much more about a complete rewrite than it is about an adjustment and a refresh. And I suppose I'm looking for assurance that we're not throwing the baby out with the bathwater in this, that we are adapting and adjusting as we move forward with at least a 3-year horizon. And I have a feeling that we should be looking at a little longer horizon as well. But no, 3 years is the benchmark.
Thank you, John. I couldn't agree with you anymore. Absolutely, this is about tidying up and building upon what we've previously achieved. It will be absolutely inappropriate for us as an organisation to throw out medium-term planning. We've made some really good progress. Perfectly understandable that Welsh Government are looking for a focus upon some of the immediate areas, but we do need to keep that medium term, and as you say, that longer term view in terms of our planning approach. So I'm sorry if the paper looked as if we may be at risk of throwing the baby out with the bathwater, because that's absolutely not the approach we are planning to take.
All right, thanks, Chris.
An important point, and thanks for the response, Chris. Linda.
Diolch yn fawr, Chris, ac dwi'n deall bod na herio ymlaeniau ni, ac dwi'n gobeithio fydd y Pwyllgor Partneriaeth Cynllunio a Iechyd Cyhoeddus hefyd yn rhan o'r broses. Ond ga i ofyn, oherwydd oedden ni wedi cael dipyn o drafferth i gyrraedd yr amserlen i roi'r cynllun gwreiddiol i fewn. Ga i ofyn beth i lefel y hyder chi ar ran bod yr adnoddau gennych chi i cyrraedd y nod erbyn Ionawr 2023. Dwi'n sylwi bod dim ond 3 mis gennym ni i adnabod y blaenoriaethau a trafod efo Llywodraeth ac yn y blaen. A dwi yn derbyn yn llwyr bod ni yn adeiladu ar y gwaith sydd eisoes wedi gwneud, ond ar sail y ffaith, dwi'n meddwl bod o'n deg i ddeud bod ni wedi cael heriau i gyrraedd yr amserlen yn gynharach. Ydy'r adnoddau gennych chi i gyrraedd y nod o tro yma? Diolch.
Thank you, Linda. I'm confident that bar any unusual requests or sort of changes to any of the planning guidance that might be outside of our control, that we will meet this timeline. We're already well through conversations with teams throughout the organisation in terms of where our focus should be next year. Indeed, many of those conversations build absolutely upon the conversations that have been required for the clinical services strategy paper we've just discussed. And I'm confident that my team can do their necessary part along with the other corporate teams that are absolutely part of our planning process. So I am confident that we can have this complete and to the board in the timescale that is outlined.
Just on that point, Chris, can we agree that first of all, the response to the issues identified in the letter from the Director General about the IMTP that we submitted will be reported to PPPH, chaired by Linda, and secondly, in terms of the timeline that you've set out, Chris, can we agree too that the progress against the timeline will also be reported to PPH as we move forward, please, which I think is on Linda's point.
Yes, absolutely. The team have already worked on that, and yes to both.
Linda, does that meet with your agreement, please?
Yndi, Mark. Dyna, I ddeud y gwir, eisiau cadarnhad â ni bod ni'n mynd I cyrraedd y nod ar y sail bod hyn yn gymleth, a dio ddim yn hawdd I adnabod y blaenoriaethau'n symud ymlaen, ond yn derbyn yn llwyr bod y cydweithrediad gyda Chris a'r Pwyllgor yn un da iawn. Diolch yn fawr.
Thank you, Linda. The up and out. Chris, there's a note in the chat from John Galanders that I'll leave you to respond to, but I'll come to Claire next. Claire.
Diolch, Chair. I guess my points kind of build on both what John and Linda have already said in a sense, which is that absolutely for me, we've got to be thinking in at least 3-year terms, particularly in terms of the challenges we face around delivering efficiencies, savings and addressing backlogs. So kind of welcome Chris's response around that. And I guess then linking into kind of something Linda said was that this the action plan around this kind of predates today. So there were a whole load of things planned to be completed in July. So I guess it's a question of have they been completed and has there been anything fundamental that's come out of the horizon scanning work that was due to take place before the end of July? Thanks.
Yes, thank you, Claire. So again, absolutely agree. The long-term planning and that is recognised through the team. And in terms of the work undertaken in July, we are entirely on track. We've had a number of conversations amongst teams in terms of what some of the priorities for next year might be, going to the horizon scanning observation that you make, and we will continue to bring sort of iterations of that planning cycle through PPPH to stick to the timescale outlined.
So on Claire's point, Chris, is there anything that in those 4 areas that were due for completion last month, including the horizon scanning, is there anything that falls out of those items that we should be aware of now?
Not that we should be aware of now, but I would be doing injustice to the team if I just told you what was on the top of my head. What I'll do is I'll circulate around a brief outline of what came out.
Thank you. That would be helpful. Much appreciated. Thanks, Chris. Richard.
Thanks, Mark, and thanks, Chris, for this. It's disappointing that the 3-year IMT hasn't been accepted. So we need to redouble our efforts and make sure that next time round it is. Looking at the plan, you go on page 8, the timeline over the coming months. I was going to ask the question that Claire asked, but focusing on the other area that's causing me concern, you've got financial planning principles, which you've scheduled for September. Now, the IMTP, if it's to be accurate and effective, needs to be aligned with our budget for our 3-year budget that starts for next year. Our budget isn't set in 1 month. It takes many months. In fact, it should have started already, but I don't think it has. What exactly do you mean by financial planning principles, and how will you ensure that the budget, well, when we will see a budget timetable, and how will that be integrated into this? Moving on to the next part, we've got workforce assumptions, and it's a similar question. I don't know what workforce assumptions are. We should have a workforce strategy that needs to be refreshed so that it is all current and topical when the IMT comes up for approval in due course. So there's those two questions about how those two particular items work in the context of this diagram and the timelines. But there are also two other equally important areas of resourcing that need to be given the same level of attention, and they are an estates strategy, which off the top of my head I think we haven't updated since 2019, and a digital strategy, because in the modern world many things are digital and they cost money and they have timelines associated with them. So how will you go about refreshing this plan to ensure that the budget, the workforce, the digital and the estates are all refreshed on a timeline that works with this, culminating in approval based on your diagram of January? Thanks.
Thank you, Richard. The diagram is intended to be very sort of high-level walk through. I agree that some of the language in trying to keep it high level sort of allows various interpretations. In terms of financial planning principles and review of workforce assumptions, those two references are very much to any of the programs that are requested of teams. During September, there will be a concerted testing of those against our finance workforce and indeed other resource requirements to your point on estates and digital. What we do know historically is that those testing steps have not always been as robust as they could have been, and certainly last year we benefited significantly from a much more tight and extensive testing against a range of resources. So I wouldn't want anybody to interpret that all of the financial and workforce planning for our organisation occurs in September and September alone. The IMTP, all of our planning now is done as an integrated planning process, and so colleagues are involved all the way along. The bit in September is specifically about testing any of the specific requests for next year's IMTP that individuals put forward within this cycle against the resource available.
I think also Sue wants to comment, Richard. I'll let Sue come in next before I come back to you. Sue. Sue, we can't hear you.
Apologies. Richard, just a couple of points I'd like to give some clarification on. In terms of the financial planning principles, we have a detailed timetable coming to PFIG in August that will give flesh out a bit more detail. Effectively, we will have agreed that hopefully in PFIG, and then we will work through the detail of it in September. And obviously we have a further PFIG committee in October. The financial strategy is also coming to PFIG in August, so that sort of lines up with Chris's timetable. In terms of the estate strategy, although it was last approved in 2019. It didn't expire until March 2022. And the capital report that we're about to go through later does talk about the revised estate strategy. We've got 3 outputs from it, which will be ready sort of November time, which does fit into Chris's timetable in terms of making sure that we've got something available in December. And I'm happy, obviously, to talk about that in more detail as part of the capital update. Thank you.
Thanks for those observations. I'm a little concerned now that we've got a Gantt chart showing the progress over the course of the coming months in January, which we're told is illustrative only and not in any level of detail that we can be confident in. Yeah, I hear what is said about estate strategies being from 2019. All of these strategies need to be refreshed every single year if we are to have a credible IMTP. Otherwise, we run the risk that next time round the Welsh Government will say, yeah, that's fine, but you haven't got all these supporting things in place in a refreshed form.
To Richard's point, Chris, are we expecting to adhere to the high-level timeline that you've laid out in the paper?
Yes, I don't think I intended to say that these were illustrative only. My point is that during September, we will specifically test any of the schemes put forward in July and August to absolutely satisfy ourselves as a corporate teams that they absolutely stand against the resources requested. That is my point. This is not illustrative. We will work to this chart.
Right, and then in terms of Richard's valuable point about annual review of the strategies, that is ordinarily built in to the strategies. For example, the people strategy, if I remember rightly, had milestones for years 1 to 3. Can we confirm that as part of the annual planning process, delivery against the strategies by year will be, and the next year will be built into the planning cycle?
Yes.
Sue, agree.
Thank you, Mark. I think you've just picked up my point. So it is already in the planning cycle. We refresh the deliverables in each of our annual plans and have done that for the last 3 years for both people and estates. But clearly what we don't do is to develop a rolling strategy document, because we need to provide clarity to our workforce. They need to be able to see that we are delivering against that 3-year strategy and then go through the full refresh as we go into the final year. So I think there's a suggestion that we haven't been doing that. I think if you look back at our annual plans, you'll see that has been done, but appreciate it needs to be maybe a little bit more explicit for colleagues.
I think it does, in terms of the fact that the development of the plan this year, albeit not accepted as a 3-year IMTP, sought to ensure that there was a read across from the enabling strategies, as they've been called, with the IMTP. We need to continue with that discipline, don't we? I think we all recognise that. On occasion in the past, it's probably not as been as strict as it should have been. Well, I think we've all agreed that it ought to be stricter. So let's just agree that that is the intention, and we will need to monitor it as a board and prove PPH that part is part of the process. John C.
Thanks, Mark. On the digital strategy, I'm aware that Dullan, as somebody new, is reviewing the digital strategy from the conversations I've had with him. So I'm confident that will be reviewed and taken forward. More substantive question, Richard sort of touched on what I was asking, which is about, can we accelerate the sort of the workforce and the financial parts of the plan? But I just wondered whether we need to separate out the savings side of things. Maybe it's a discussion of the finance paper, but we're in the first year of what would have been a 3-year plan. We're overspending and we're under-delivering on savings, and that's key to us being having a balanced IMTP going forward. And if we don't identify savings and concentrate on doing that, we're not going to be able to deliver the plan as it will be laid out. How do we get assurance that that is fundamental and is looked at in the level of detail needed to be able to plan this going forward?
Sue and Jill, I know you've got your hands up, but I'm not going to come to you because we're now 11:15 and we are running way beyond the timeline. What I propose is that that the observation has been noted, that Chris seek to respond to them with your assistance as necessary outside. But I want to come to the financial strategy and the savings program when we get onto the finance report, and I want to come to the state strategy when we get to the capital report. So two of the things that John has mentioned, we will be returning to during the course of this agenda. So with all of that said, are we happy to note this report, the timeline set out, and the agreement now reached that it will be monitored both in terms of the responses to the letter from the Director General and also in terms of adherence to the timeline through the committee, which is PPH. Yes?
Yes.
John?
Yes.
Thank you. Thanks, Richard. Thanks for all the contributions that have been made, which undoubtedly were valuable. So, Chris, I'm going to come on to the final item before we have a break, and that is the transformation and improvement update. Again, can we take this as read, please? And can you highlight anything particular you wish to highlight, please?
Yes, thank you, Chair. There has been an awful lot of work gone on in what is a very young team, and Joe referred earlier to some of the challenges that this team have in terms of the capacity of so many areas in which they're needing to cover, and I can't stress really how much work has been undertaken to build those foundations. I did promise previously that we would start to see the outcome of that foundational work, and the paper refers to two items I draw your attention to. The first is our approach to continuous improvement, and I think there's a graphic on page 5 that just starts to touch upon that, and what you will see coming through in the coming months is the digital newsletter that sits alongside this, showing that toolkit in practice now that it has been launched. It's been tested with a number of service-facing colleagues already with good effect. So we'll start to see some really good stories come through there, just to show the extent of work which is going on within BCU, but not always visible. And then the second point with regards to pathways, you will see now the first few pathways coming out. They're just being prepared for publication now. We've got carpal tunnel, hip pain, knee pain just being finalised now. Colorectal and prostate cancer pathways are progressing, not quite ready for publication. Likewise, the dementia pathway. They're all important pathways. They're high volume pathways, and pathways where there's lots of scope to do things with greater value. What you will see when we publish them is the professional guidelines, but also a huge number of resources for patients, including videos, including prompts for individuals to give their feedback, and including a cohort of audit tools for each pathway to demonstrate that we are in fact adhering to them as we go forwards. So very brink of seeing those come through, and I will bring them to your attention as soon as they are published, but very much welcome that as being an important step.
Thank you. Any observations, Lucy?
Thank you, Chair. Thank you, Chris. How are these improvement and transformation programs actually prioritised, please?
So historically, when the team was established, we had a number of areas of transformation which we have adopted and done some work to tidy up and improve. We then have had extensive conversations amongst the exec team about how we do need to focus upon a smaller number going forwards. We have 5 or 6 programs at the moment. There is always the temptation to add in another one. Indeed, we've just added in Glenclwyd for very obvious reasons. So the team collectively, the exec team collectively, decides upon which areas we should focus. And we have a range of different approaches to that, including return in terms of the number of patients that would benefit from that particular activity, through to sometimes the seriousness of individual areas or opportunities. As I say, we have about 5 or 6 at the current point of time, which the exec team feel are the minimum number.
Okay, thanks, Coke. The reason I ask is I wondered whether there was any kind of risk assessment undertaken, given the the concerns that as you're aware, that the QSE committee have raised, that really does require. I know you've referred to the theatre checklist being one of the subjects that this improvement process is being applied to, but safety to me seems to be the first priority, to make sure that we are reducing harm to our patients.
I can see that Joe may want to come in, but safety runs through all of them. What is important is that we group them into chunkable pieces of work into specific programs. So safety runs through the unscheduled care program, safety runs through the planned care program, safety runs through the mental health program, as 3 examples of those programs.
Joe and then Jill.
Thank you, Chair. So, Lucy, as we see the refreshed corporate risk register, you'll start to see a strong cross-reference to issues of risk with areas of improvement as outlined in the transformation update. For example, within the YGC improvement plan, stream 1 identifies a series of BETSI-wide improvement priorities, which are entirely drawn from the evidence associated with the most commonly occurring significant incidents, so falls, pressure injuries, and so on. So there is a read through to risk and patient safety, as well as an opportunity in some of the other improvement themes associated with planned care to build on interest and enthusiasm. But as Chris has said, through all of those interventions, core to each is the principle of improving patient outcomes and patient experience. Thank you.
Thanks, Joe. Jill?
Just to support what's been said, Chair, if I may, when we're looking at the pathways, I would reiterate that this is enabling us to put evidence into practice consistently across the health board, and that mitigates a significant risk in terms of the way that we deliver care to ensure that we are delivering it consistently. So I just want to reiterate, if we take the getting it right first time and the carpal tunnel and the orthopedic, this is ensuring that not only we take the PREMs, so the patient experience measures, and the PROMs into context when we rewriting those pathways. So all of that is taken into account, and absolutely support Joe's point that there is inherent within this, there's also work undertaken on our most significant harms.
Thank you. Thanks, Jill. John C.
Thanks, Mark. It was just on the back of what Lucy said, just wondering whether we need, from an insurance point of view, visibility of what's in the list of programs, maybe stratified in the same way risk is done, in terms of the contribution of a program that might be, or the impact it's going to be making to patient outcomes, or how it's going to improve serious risks. How do we get that visibility that the prioritization is appropriate and is going to make the best use of our resources in terms of contribution to the services that we have?
Joe, then I'll come in.
Thank you. May I suggest, with Lucy's agreement, that might be a matter appropriately delegated to QSE?
I think that might be a starting point, but somewhere, I think Lucy and John make the point around the board needs assurance that the investment that's been made in this team is being aligned to several things. They include delivery of the IMTP and the priorities set out in there, and secondly, the risks and the key risks that exist, either in terms of patient safety or some other matters that appear in our corporate risk register and back. So a clearer translation, Chris, of or description of the alignment in that regard, I think, is what's been sought here. Yeah. I'm happy for it to be discussed at QSE, but I think it's broader than that. And perhaps, I know you would think QSE, we do what I've just asked, Chris, in terms of the reporting moving forward?
Yes, we can do that.
Thank you. And as John has put in the chat, Chris, it also applying to TI.
Yeah.
Can we will come to this in the finance report, Chris, but I'll give you and Sue notice of that fact. The finance report refers to the delivery of the savings program being equally split between transformation and transactional. And at this point, 3 months into the savings finance year, we have no transformational savings delivered or identified, it would appear. Now, I'll be wanting to discuss that when we get to the finance report.
Okay.
Thank you. All right, so if you're happy, colleagues, will note that update, and we've agreed a couple of actions to pick up as a consequence of the update. So thanks, Chris. Are colleagues happy to note the update?
Yeah. Yes.
Yeah.
Thank you. All right, so I'm going to move us into a comfort break. We are now running half an hour behind, which is something, as you know from what I said at the start, I wanted to avoid, but nevertheless, I can't curtail conversation where the conversation is really important. So we will break now for a break, comfort break, coffee, call it what you will. It's 11:30. Can we return, please, at 22? Thank you. Okay, it's 22. So I'm going to take us back to the agenda. We have 4 items now under the risk section. And Molly, the first 3 are with you. So bearing in mind my previous request for brevity as far as achievable, Molly, can you lead us into the first item, please, which is the risk management strategy? Thank you.
Thank you, Chair. So this strategy is presented for board approval, having been submitted to Quality Committee, Quality Safety and Experience Committee, and Audit Committee for consultation. So in the interest of time, Chair, if it's acceptable, I'll just take you through section 3 in light of some of the concerns raised earlier, and also the recommendations, and then take any questions. So one of the main implications of implementing the strategy is that we'll have a more refined integrated assurance infrastructure, which will allow us to triangulate information more proactively and allow us to manage and mitigate risk more dynamically. And I'll just mention 2 key aspects of this. One is to align performance indicators with the corporate risk register and the BAF, so that we apply an early warning mechanism to identifying key risks before they crystallize. And secondly, we'll embed the 3 lines of defense within our assurance process, which speaks to the point raised by the chair initially about the assurance ratings that are given to areas that the board receives. So again, it's evidence-based, it's not subjective. And then I just thought it's worth mentioning as well that as part of this strategy, we're proposing that the BAF is monitored quarterly. Previously, this was on a biannual basis. And as the BAF is a board document incorporating the strategic objectives of the board, it is appropriate for the board to monitor the BAF more often. And alongside that, the proposal is also for the corporate risk register to be monitored once by the board annually. And the reasoning for that is the corporate risk register is monitored at every meeting of each committee, and also the QSE will become the key risk committee of the board. And lastly, the other main recommendation, which is the last sentence on page 4, is that the oversight of the risk management group is to be changed from the audit committee to the quality and safety and experience committee, which is in effect the more appropriate committee to have the operational management of risk. And with that, I just wanted to flag that the main recommendation is really that the board approves the implementation of the strategy and approves the implementation of the integrated assurance infrastructure, as well as the management of the BAF frequency, as I've outlined, as well as the oversight arrangements for risk management group. I'll pause, Chair, and take questions.
Thanks, Molly. John C.
Thanks, Molly. A number of points. One, in both the cover sheet and the document, it refers to PFIG taking the BAF bi-monthly, but PFIG meets bi-monthly. So what you mean is every meeting, and I'm not sure whether that language should be used instead or whether that's appropriate. The second one is in terms of the risk appetite on page 9, I think, if I get there. SO5, improve safety and quality of all services, and it's linked as cautious. Should that be open or seek, so we recognise the need to transform and innovate and improve? No, the objective is improve, not to just maintain status quo. So I'm questioning whether that appetite is correct. And then in section 10.5 on page 21, and I get to it, it's referring, so 10.513, it refers to digital strategy as part of PFIG and also IMTP, but both of those are PPPH. So I think they're in the wrong place. And obviously that then means that 10.6.3 needs to include digital and planning. That's my point.
Thank you, John. Chair, if I may respond.
Cool.
Thank you. So just taking them in turn, John, I think your point about the cautious approach is well made, and we've had quite a few discussions around this. I think the reasoning behind why it's cautious, not open, is due to the current risk exposure we have as an organisation to patient safety. So if we were not in the position we are in with areas such as YGC, vascular, and the high number of neuro events, we may be in a different position. But that's my understanding of the rationale behind that. And yeah, I think apologies, there's just a sort of like statement around PFIG and true pH. It was meant to be the other around. So I'm more than happy to change that. And apologies, I think I've missed your third point. Sorry, you're on mute.
Trying to get there. Yes, it was just the fact that if it is incorrect in terms of what you had in terms of 10.5, whatever, then consequently the paragraph 10.6.3 under the PPPH bit needs to be modified accordingly to handle digital and planning, because that's part of a PPPH remit.
Yes, thank you, John. And I think your first point actually was around the fact that we've said PFIG bi-monthly, and you wanted it to say at every meeting, so I'll make that adjustment.
Well, it's a matter of do we see this as being reviewed more frequently? Because if it does, then it may be at some point PFIG changes, but at the moment it's bi-monthly. It just feels a nonsense to say we'll see it bi-monthly when the meeting actually is bi-monthly.
Yes, I think the point was trying to illustrate how often it's done at committees and not at board, which is biannual. So, but yes, I think your point is well made. I'll make that adjustment.
Thank you.
Thanks, John. Thanks, Molly. Any other observations before I move the recommendation? Linda.
Diolch Cadeirydd. Hwyrach dros sylw ydi o. O'n i'n meddwl sy'n ni wedi disgwyl clywed chydig bach mwy o gyfeiriad at fframwaith ymyrraeth wedi targedu. Oherwydd mae hyn yn mynd i fod yn prif pynciau'r bwrdd dros y 2 flynedd nesaf, y bynnag. O'n i'n meddwl hwyrach byddwn ni wedi clywed, sy'n ni wedi disgwyl hwyrach gweld cyfeiriad ato fo. Dwi'n gwybod os gen Molly unrhyw sylw i roi.
Thank you for the question, Linda. So I suppose my initial feedback is that the framework is what we're using at this point in time. We've not mentioned specific regulatory frameworks, but I'm more than happy to include that, because you are right, we went from special measures to TI, and TI is a very key part of our improvement of assurance as well. So I'm more than happy to put something in there specifically addressing that point and how that takes us forward in risk mitigation terms.
Diolch yn fawr.
Hi, sorry, I may have been on mute. So just taking you to the recommendations on the cover sheet, we are asked to note and approve the implementation of the risk management strategy, note and approve the integrated assurance infrastructure approach, approve the revised approach to reviewing and monitoring the BAF, approve the revised oversight arrangements for risk management. So taking into account the responses that will be provided and included in terms of John and Linda's comments, are you happy to go with the recommendations?
Yes.
Yes.
Yep.
Thank you. Right, Molly, let's move on then to the next item, please.
Thank you, Chair. So based on the approval of the board of the strategy, I suppose I just want to mention that that means also that the format of the BAF is approved. But I just thought for consistency, I ought to ask the board to approve the format, which is based on the provisions of the strategy. So I'm just going to take you through a couple of the sections of the body of the report if I may, Chair, and then I'll take questions. So the board had a workshop in June where we met to look at the legacy BAF and what proposed actions were resulting of that. So there isn't anything material for me to highlight on that, except to say two things. So the first is Chris gave an IMT update earlier, and as part of that consideration of where we are with the IMTP, we then made a judgment that we should include an IMTP risk, which is in section 2.4 of the BAF, and that's in line with being consistent with the fact that we need to continuously review and prepare for the next cycle. And then the second aspect of the update is that when we met in June, there was specifically a comment made about the finance risks. So at the time, we had separated the savings risk from the financial break-even duty risk. And as a result of the feedback, we have now merged those two risks. So that's as a direct result of some of the development of conversations. And then I just thought it might be worth highlighting to colleagues as well, section 4, which sets out the new risks that have been added to the board assurance framework. The first one is YGC, also part of the workshop. And then I've just mentioned one additional risk, which wasn't part of the workshop. And that's risk 1.7. This is pertaining to delays in medically fit for discharge patients as a consequence of shortfalls in resources within the social care environment. So these are the risks that are the sum total of what we'd reviewed at the workshop, as well as what we've updated. So I'll pause and take questions because I can see there are 3 hands up, Chair.
There are. Thanks, Molly. John C.
Thanks, Mark. Thanks again, Molly. It's really just a plea in terms of the actual presentation of the BAF. You know, a tabular spreadsheet version of this makes it very difficult to read and grasp and assimilate the risks that are there. Can we present this as a page per risk in the BAF or something different? Because it's even zoomed in it, with the text being so small, it's difficult to grasp it all coherently.
You need to bear in mind, Molly, some of us are older than you.
Thank you, Chair. So if I can just respond to that. So John, apologies for that. I'll certainly look into it. The aim was to try and align the risks alongside the living healthy, staying well objectives. So I'll have a look at how we can do that and make the text bigger and maybe make the document larger as opposed to cutting across the objectives.
Thanks, John. Thanks, Molly. Claire.
Thanks, Chair. I have really deep concerns about the content of this report. So the format of how it's reported to us, I'm absolutely fine with. I guess my concerns are that nearly, I'm sure I'm almost right in saying 100% of the risks are all identified as kind of deep red. There appears to be many deadlines which are passed and not acted on to mitigate or reduce the impacts or the likelihood of some risks occurring. There are some things where I read the document and it just feels far too passive and not proactive enough. So if I use the example around hospital discharge that Molly just referred to, we talk about waiting for a regional partnership workforce board to meet. Well, why aren't we making that meeting happen rather than using that as one of our reasons for why we've not been able to progress things? So I could, almost every single one of those risks I read, and it gave me cause for concern about whether we are given sufficient time, given sufficient actions to addressing and mitigating and minimising some of these risks. So format I don't have an issue with. It's more about actually our risk management within the Health Board.
I agree wholeheartedly. Molly.
Thank you, Claire, and thank you, Chair. So, Claire, yes, agreed that the BAF is an extract from the risks deemed most significant to the delivery of the strategic objectives. However, I would also refer the board's attention to the cover sheet, which says that there is partial assurance given on this paper, mainly because there are either some risks that are outside of our risk appetite, or there are significant gaps in controls and assurance. But having said all that, there is an ongoing effort to try and get more robust controls. For example, the one you gave us is one that I've just recently discussed with Jill as part of our regular review of the risks. So I think it's a fair point around where we are in terms of our risk maturity. It's one of the things we need to improve on, but also in terms of the assurances that we have in place. So I'll take that away and make sure that that's included in the next committee update for that specific risk as an example.
Yeah, thanks, Molly. I think actually on each of them, for me, you know, a lot of the capital and asset-based ones, you know, we talk about failing to meet statutory minimum standards, and we need 3 more people to do water testing. Well, it ought to be in our gift just to kind of get some of those actions addressed and moving forward. So I think there is a fair bit of work needed on this to make it far more robust. Thank you.
Thanks, Claire. Lucy.
Thank you, Chair. So I think there is we can do with strengthening some of the internal and external assurances, because I've identified some gaps in there that actually we could add more detail on those areas, but I'm happy to take that outside the meeting, Molly. The bit that I just wanted to specifically highlight is on page 3, and it's risk number 3.2. So this is about the listening and learning. The way in which the principal risk has been worded suggests that this is a risk for listening and learning generally for the organisation, no matter where those concerns have been raised. And in fact, that does correspond then with a patient safety report that is on the agenda later on, because that specifically refers to the listening and learning risk on the BAF. However, judging on the controls that have then been highlighted to manage that risk, it seems to actually be all about staff raising concerns and listening, learning from staff. Now, if that is the case, then I think the risk needs to be reworded. But actually, I would argue that it shouldn't just be about staff raising concerns anyway, because as we'll come on to on my chair's assurance report, we are still concerned that we are not listening and learning as an organisation, generally speaking, not just when our staff raise concerns, but when our patients raise concerns, when our stakeholders raise concerns as well. So I think that is a really key one, in which case it's the controls element and the gaps in the controls that need to be addressed.
Molly.
Thank you, Chair. So I think what I'll propose to do, Lucy, is to give this some more consideration with some colleagues, but I think it's the latter. My initial reaction is it's more of the latter, and we need to work on the controls and the gaps in insurance. But I'm just going to take an action to clarify that and to provide the update via the QSC iteration that comes in the September meeting.
Thank you.
Thank you.
Can I offer an alternative suggestion, Molly, or one in addition to what you've described? Because not all of these, of course, rest with QSC, and I'm with Claire. It's seeing the BAF, seeing the gradings listed therein, seeing the number of reds identified, and with Claire feeling not as assured as I should be about the responses, and particularly the controls that you just alighted upon, but in particular in relation to QSC. I wonder if Claire and Lucy are happy that we do what you say, but take it outside more broadly to have a conversation about how we get this to a place that would be suitable as a platform for assurance, or more suitable than it is currently. So if Claire and Lucy are happy, perhaps Molly could take that outside, and you could, with Joe, identify a lead executive.
Yes, Chair, thank you.
Yeah, I think that's helpful, Mark. Thank you very much.
Okay, Joe, will you let Molly know who you will appoint as the lead in that regard, please?
Yes.
Thank you. So, Molly, where does that leave us in terms of your recommendations in the paper from your perspective, please?
So, Chair, I think in terms of some of the feedback we've received, it'd be worth clarifying whether the the board is happy with the format of the document and the approach to monitoring it as set out in the strategy and the report. And then we can take away the more material actions around the individual risks. So I think in terms of approving the recommendations, I think we can proceed noting the improvements that are needed for the individual risks.
Okay, and I think, unless John corrects me, I think John was saying he was generally happy with the format. It's just difficult to read and follow. So having it presented in a different format or in a different manner would be helpful, I think. He's not questioning, I don't think, John, unless you tell me otherwise, that you know, the nature of its construct in terms of the columns and the information that is intended to be reported. John, is that correct?
I think the columns and the content that's meant to be reported are fine. I think the difficulty that on the underlying point for me with the format is that if you can't read it well or easily, or you've got to scroll left, right and centre, you can't grasp the risk and whether the mitigations and the controls are appropriate to dealing with that risk. So that totality of the reporting as it stands at the moment, I'm unhappy with. The content as it's set out as columns are the right things, but I don't know whether I'm not confident that what's in there, as Lucy's highlighted on one in particular, are appropriate to be able to deal with that risk.
Yeah, okay. I think we are generally saying the same thing. Are you happy for us to take it outside and report back, John?
Yeah, I'm happy to do that. I'm happy to be part of that conversation if necessary.
Okay, all right, thank you. Molly, note and approve the actions agreed at the June board workshop for the legacy BAT was the second recommendation or request of the board.
Yes, Chair, and the reason why is because we had a legacy BAF. We should note what we've done with it formally.
Okay, thank you. And then note and approve the adoption of a new BAF risk summarised in section report as well as the BAF document. We can, subject to the conversation actions we just agreed, Molly, I think. So our colleagues with those caveats happy to do what the board is being asked to do, as I've just described.
Yes.
Yes.
Okay, thank you. Molly, keep going. So we're on to the sword.
Thank you, Chair. And I'd just like to express my thanks to Sue Hill and her team for helping us to arrive at this position. So between March and June 2022, a lot of work has taken place to arrive at a centralised scheme of reserve delegation, which is what we have in front of the board today. So this version of the document has been through the audit committee and reviewed what the changes are, which are highlighted in Appendix B of this document. And so the main purpose of the document is really to allow a standardization of the application of the scheme of reserve delegation. And it's particularly pertinent now that we're implementing the operating model. So in terms of the next steps, I'll just highlight those quickly, Chair, as I'm conscious of time, and then maybe we can go to questions. So the sword will continue to be developed as we implement the operating model. However, it's not anticipated that there will be any material changes to the document. The audit committee will receive updates on its development over the next 12-month period. And also there are highlighted changes within the document, which actually give assurance that there isn't any uplift of approval limits. There is more incorporation of the integrated health community roles and responsibilities. And then point 6 is quite important in terms of the fact that we've got a second line of defense in the work and oversight of the finance teams and how they'll be supporting the IHCs and divisional management teams. And this is particularly pertinent in terms of just ensuring that there is a reduced risk of ultra-vires sort of transactions. And this is specifically aligned to the overall governance and assurance framework, which is part of the operating model. So I'll just pause there, just being mindful of time, Chair, and take questions.
Thanks, Molly. John C.
Thanks, Mark. Thanks, Molly. Page 22 on Appendix A, item 47. Is that correct? Because as IMs, we have a statutory duty in terms of approving consultant appointments, but the SORD says chief executive and then operational responsibility exec directors.
Sue.
I think John is right. It is the board that has authority that delegates to the representative of the chair of the AACs to approve consultant appointments in the statutory instrument.
Molly, could you check, please, and adjust?
Yes, apologies, Chair. I was just going to get my mic off and say yes, that's absolutely correct, as Sue has indicated.
Thanks, Sue. So that will be adjusted. John, anything else from you?
Not at the moment, thanks.
Thank you. Thanks, John. Richard?
Thanks, Mark. A couple of questions regarding section 12, which is charitable funds held on trust. That's on pages 13, 14. Am I correct in assuming that this refers to our LAS, or is it to other charitable funds held in trust? And a more legalistic point, given that we say here that they are held in trust, and if it indeed it is our LAS, our control over these things is not the same as our control over everything else that the Health Board does. It's in our capacity as trustees of a charity. And I would have thought that the wording in the document therefore would be different to reflect that trusteeship relationship. In fact, arguably it should be in a separate document, I would have thought. Could you confirm that and perhaps shed light on how this relates to the trusteeship role more generally? Thanks.
Well,
Thank you, Richard. So I think you're right in terms of the fact that the charitable funds are in relation to the charity, of which the Health Board and the Board of Directors are trustees, are corporate trustees. So part of the challenge with this document, Richard, is that it's based on the All Wales scheme of delegation template, but there's nothing stopping us from saying wherever we've referred to our execs, that this is in the capacity of the trustee accountability for structure. So we can actually make that quite clear, because that's the context that this is written in, and we can just make it explicitly separate from the fact that we're talking about the individuals that are discharging the roles for the Health Board, and also the individuals discharging the roles for the trustees, if that makes sense.
thanks, Molly. Lucy?
Thanks. On page 12 of the SWORD, it refers to suspension of doctors employed directly by the Health Board and then removal of practitioner from the performers list. Would that be better worded to say any action under the performers list regulations? Why are we calling out specifically just the removal?
Sue, can you help?
We shouldn't be. Lucy's correct.
Could you adjust that with Molly then, please, Sue?
Yes, there are a couple of things I think have got lost in transcriptions. There's a couple of things I think, particularly AAC, particularly around UPSW, and a couple of other ones that I think we will need to adjust.
Right. So can I ask you to do that then? And Molly, could you recirculate for our information with the adjustments shown, please, in due course?
Yes, Chair. Thank you.
Thank you. So with all that said, and noting there will be adjustments, are we happy to note and approve the proposed changes with the additional changes just highlighted as set out in Appendix B? Are we happy to note and approve that there will be a need for continued development of the next level of the detail ready for implementation alongside? It says OM go live, but OM has gone live. So I'm guessing, Molly, Sue, that will need to be prioritised as a piece of work. And 3, note and approve continued oversight by the audit committee over the next 12 months. Linda, you've got your hand up.
Diolch Cadeirydd, dim yn ymwneud â'r pwynt yma os ydych chi eisiau gorffan y pwynt ydych chi wedi codi.
Right, okay, so are we happy to follow the recommendations with the caveats I've listed?
Yes.
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 Okay, thank you. Thanks very much. Linda.
Mae ddrwg gen i cymeryd amser y bwrdd gyda hyn a na i fod yn gryno, ond tra bod Molly efo ni, ydy o'n bosib i cael cadarnhad a bydd y sefyllfa ynglyn â anghysondeb yn y papura bwrdd, enwedig yr papura cychwynnol bob eitem ar yr agenda. Ar hyn o bryd, mae gennym ni sawl un sydd dim ond yn Saesneg, a mae gennym ni sawl un sydd yn hanner a hanner. Felly, Cadeirydd yn fras, ydy o'n bosib i gael cadarnhad bydd y sefyllfa wedi wella erbyn cyfarfod nesaf. Ar hyn o bryd, dwi'n credu da ni ddim yn cyrraedd ein dyletswydda statudol gyda'r iaith Gymraeg. Diolch.
Just on that point, Linda, we agreed certain things in that regard, didn't we, at a previous meeting? So presumably you're saying that we ought to be complying with what we agreed as a board.
Wel, yn syml, ac y tro yma, mae'n anghyson, mae rai ohonyn nhw'n Gymraeg, mae rai ohonyn nhw'n Saesneg yn unig. Felly, dim ond angen cadarnhad ydw i, bydd y sefyllfa wedi wella cyn ein cyfarfod nesaf. Diolch.
Thank you. Molly?
Thank you, Linda. Thank you, Chair. So I will go away and come up with a proposal for you to consider, Chair, in terms of how to take that forward, take into account the previous discussions we've had on this.
Okay, Joe?
Diolch yn fawr, Linda. To confirm that I've put some control arrangements in place when this matter was brought to my attention to ensure that we're all clear about the correct bilingual templates and commitments we have made. And I referred earlier to an improved standard operating procedure and the issue of ensuring bilingual cover papers and reports are provided where that's appropriate is part of that. Thank you.
Dwi'n diolchgar iawn, Jo. Diolch yn fawr iawn.
Now, Linda. Okay, I'm going to move us forward then. So, corporate risk register. Nick.
Diolch, thank you, Chair. I would assume board members have read the risk register report and would note the considerable amount of work that's taken place since last January. I would say, however, that I think there is a considerable amount of work still to take place to ensure that the corporate risk register really reflects the health board as we know it, with the many challenges and issues which have already been described in this meeting. I think there remains also further work in order to ensure that there is consistency of assessment of risk across the whole of the risk register. However, I think that is significantly better than the time the board last saw the report. On page 3 of the report are the top risks ranked by residual risk rating, and on page 4 the new risks. Before taking any questions, Chair, I would point out that risk 2111 is taken in private board around the digital risks for obvious security reasons, and risk 4476 has not been gone through the committee process yet. So whilst it is referred to in the report, it won't appear on the risk register until after the meeting of QSE next month. I apologise for two ambiguities in the report. Appendix A and Appendix 1 are one and the same. And on page 1, the cover sheet of the board report, under the justification for the partial assurance, some of the text has been lost because the box didn't expand. But very happy to take any questions, Chair.
Thanks, Nick. Claire first.
Diolch, Chair. I think it was just to say that from my perspective, I think the BAF and the corporate risk register are inextricably linked. And it might be helpful for the future if we're looking at the two on the agenda together to have one following the other. So suffices to say that my comments in relation to the BAF are absolutely the same for the risk register. Thanks, Nick.
Thanks, Claire, and noted. John?
Thanks, Mark. I'm not picking out individual risks, but because we've looked at these and continue to look at these on a regular basis by committees and things. But my worry at the moment with the number of risks that we've got there is that we're not being objective consistently across all the risks in terms of the scoring of impact and likelihood. I know there's a process and there's a risk management group, but it feels like it should be abstracted from people's involvement to an extent to be able to clearly identify what impact a risk will have and what the probabilities are to be able to come up with the scoring, and to try and do the same with the mitigations and controls that will reduce that risk and try and get it down to the target level. It just feels like there's still an element of, well, for sake of argument, somebody wants to bump a risk up to increase its importance rather than it being objective in terms of how much of a risk it really is. There's also risk. I think there's also an issue, I think, where we're losing some of that, the way the risks are described from that structure that we established when this format was put in place. It's becoming more narrative again than it is clearly saying what the cause and effect is.
I agree, John, and it has indeed been the focus of the risk management group and will remain the focus. And I think, as I said in my opening comments, a lot of more work to do. I couldn't agree more.
Okay, and that work will continue then, Nick. Lucy?
Thank you. So John's picked up one of the points that I made in relation to the consistency of the scoring, and two in particular jumped out at me, which was the lack of resuscitation training being scored higher than the nurse staffing levels, given our vacancy rates at the moment. And it just kind of, you know, the number of people that need resuscitating, how is that? It's the impact side of it, I think, that is problematic. And the same then with the Legionella and the asbestos risks being scored the same as the CAMS risk, considering our performance and the impact that has on families and patients in our CAMS services. But I also just wanted to pick up that in relation to some of those, the asbestos risk, the contractor management risks, the Legionella risk, they were first raised in 2020, and yet here we are now, more than 2 years on, and we're still at that level. It really shouldn't be that difficult, which suggests to me that the risk management process isn't working as it should do. And I think we need a lot more assurance on how this process is going to be going forwards.
Thank you, Lucy. I take both the specifics away, but also agree with many of the wider points that you've made. I suspect some of this is not only the risk management process, but it's also the focus in some areas that the increased focus we need to put in to address some of those risks. But I agree, and we'll take those specifics away as well.
Some of the observations are the same, Nick. I see that Joe has nominated you to join the group around the back. Let's pick it up there, shall we? And you know, whilst I'm sure we all acknowledge the attempts being made here at progress, and there is progress in terms of the nature of reporting, there's still scope to improve, which you've just recognised. So let's agree we're going to do it in that forum too.
Thank you, Chair.
John G.
Yeah, just following on from Lucy's point, it would be very useful as a board, I think, for us to identify where we're actually failing with our statutory duties. Lucy's just highlighted issues like asbestos, but we've also got asbestos, water, we've got fire, all of which, as a board, we have a statutory duty to fulfill. And there are significant risks to the board for failing on that. So I do think we need to pull those out and actually look at those separately. So that's the first point. And the other one is just with a specific to do with the timely access to care homes is highlighted as a risk. I wonder in view of the practice of care closer to home, and the fact that a lot of people are not going into care homes, but we need to support them in the community, whether that risk is actually appropriate and needs expanding to cover the current climate. Okay, thanks.
Thank you, John. We'll take away the observation around statutory duties and consider how best to present that and ensure the board is aware, and take your point also around the care homes. We'll take that specific away for consideration too. I think you may be on mute, Chair.
I am, thanks, Nick. So I have a number of execs with their hands up now. So Joe, then Jill.
Thank you, Chair. Just to confirm, acknowledging the improvements that Nick has already referred to, that conversations with our newly appointed Associate Director of Governance with regard to not only the active management of risks on the BAF and the corporate risk register, but also the way that risks are managed and escalated within the organisation are clearly part of his remit. Thank you.
Good point. In which case, Joe, presuming you'll nominate him to attend that meeting too.
Yes, indeed. Thank you, Chair.
Thank you. Jill?
It's just to reflect, Chair, that we did have a risk management group this week, and certainly the point around the care homes, John, was raised, and we've agreed to take that risk away and potentially archive parts of it, link it to the work that you've alluded to, but also to the BAF risk that was alluded to regarding the medically fit for discharge. So that won't have been reflected in this iteration because that was just this week, and that will be the same for a couple of these risks. I just wanted to make that point, Chairman.
Thanks, Jill. Sue G.
Thank you. So relating to the statutory requirements against health and safety, so the Health and Safety at Work Act and others, we are compiling a review against the gap analysis that we undertook in 2019-20, which, as Lucy pointed out, generated the risks identified at that point. We're doing that as part of the refresh of the 3-year improvement plan. So we will be bringing that through to QSE it will be in the autumn cycle. Clearly that could then come through to the board subject to QSE's view.
Thanks, Sue. And finally, Richard.
Thanks, Mark. I've got a lot of questions I could ask about individual risks in this risk register, but I don't think we have the time. What I would like to do is raise what I believe to be a significant risk that is not in this risk register, and I don't understand why it's missing. We've got risks covering asbestosis, on-site safety of contractors, Legionella, fire precautions, and we have all of those presumably because there are risks associated with operating buildings that could endanger people. Why, therefore, do we not have anything in the risk register covering the risk of inadvertently employing people who are not suited to be near any of our patients, people who may have criminal records or may be on the sex offenders register and such like? Why do we not have that as a risk? And if we have got to a situation where we have employed such people, why do we not have to have controls in place to ensure that they are chaperoned when they are in contact with patients, many of whom may be in vulnerable situations? And I ask this not simply out of from a theoretical context, but because my attention has been drawn to postings on social media recently, which appear to be saying that we have employed a clinician who has been found to have been a stalker and who had 350,000 pornographic images on his NHS computer. Now, if it's true that we have employed that person, I don't think they should be allowed anywhere near a patient. In fact, I don't think we should have employed them. So given that this is a pretty significant risk, should it not be covered in the risk register?
Thank you, Richard. Very happy.
No, can I go first, Nick? Sorry. We have to be careful here about the use of unconfirmed information in arriving at suggestions around the risk that exists or not. And I do not want to get us into territory around individuals that could lead to criticism of the board or proceedings. The point around recruitment, though, I would suggest is, do we feel that if there are any lessons to have been learned in terms of our recruitment practices of the past or of now, those lessons are being learned, that our panels are appropriately configured with the right HR support and the like, and subject to the response to those points, and no doubt more, Sue and Nick, whether we think a risk exists now or not. Sue, do you want to go first?
I think that'd be helpful, thank you, because I'm not going to focus on the individual matter, because that has previously been reported to colleagues on the board, and assurances given, as well as the full details of the circumstances that have been described. But if I focus on the overarching question, so the NHS is supported by and bound by a clear set of NHS employment check standards. Those employment check standards are administered by both my department and by the NHS shared services. We have regular compliance reports, and we do regular deep dives in terms of the compliance against those checks, where we have examples, and we have had examples of where either a check has been undertaken and it hasn't then been acted upon. We have had examples of where individuals have misrepresented their background, and that has gone through the due process. Each time any event like that happens, we fully review our processes and we try to understand how it has happened, and then put measures in place to prevent that happening. We have had in the past coronial action in terms of some of those checks particularly, and we have reported through both the inquest process and as part of our own governance processes actions that have been taken against that, and whether they have endured or not, and when they haven't, we've taken action to correct that. There are risks on the risk register that are a lower risk because of the mitigating actions that are in place. So more than happy to fully brief Richard if it would be helpful outside of the meeting on some of those arrangements, and can bring colleagues up to speed who weren't on the board when we reported on some of the examples that have been republished most recently. More than happy to go through that, but clearly as it isn't appropriate to have that discussion in the board, we'll do that offline if that's okay.
Yeah, that is. I'm sure Richard will welcome that. Just to the thrust of the point, Sue, Nick, do we think we've got an extant risk that should be appearing in the corporate risk register or not?
Yes, links to safe employment. More than happy to provide that.
So is it on the risk register in the form that you might expect it to then, you two?
Yes.
It is.
Okay, all right. Richard?
Thanks, Mark. I deliberately didn't name the individual concerned, and I had no knowledge of whether or not this was ancient history as far as the board was concerned. The reports that I'd seen were confirmed by media reports that I've also seen, but I think the issue is what are the controls that prevent us from employing such people, and where they do inadvertently get through the net, what are then the controls that cause us to detect them and remove them if it's necessary, or chaperone them, or whatever other controls are deemed necessary. I hear what Sue and Nick say about that being covered by existing risks elsewhere in the risk register. I'm happy to take that as read at the moment. I'll have a discussion later offline.
Thank you. Thanks, Richard. And that's noted. Thanks very much. So, Nick, we are asked to note and review the corporate risks in terms of the sub risks and the updates in terms of the risk movement in section 3, scrutinise and discuss the report. Our colleagues happy to do that once again in terms of the caveats that we've discussed and the further discussion that's going to take place.
Yes.
Yes.
Thank you. Right, I will now move us on to the governance section then. So we come to the implementation of the operating model, which is listed for Jill and for Sue.
Chair, if I may commence, and I will, in the spirit of time, assume that everyone has read this paper, and I'm well aware that the board has had several conversations around this subject. So I'm just going to highlight a couple of points, if I may. One of them is that we do need to read the operating model, and again, Molly pulled this out in conjunction with both the SWORD and the risk strategy, because both of these are going to impact quite considerably on the operating model as we take it forward. Several conversations at the board have referred to the governance, and the intent is that the governance will align with the board processes, hence the cross-references to the newly approved risk strategy. It will give board to floor consistency. And just to confirm the question that you asked earlier, Chairman, the EDGs are now operating. These will work alongside the operational management and accountability meetings. And indeed, we've had our first operational meeting this week with the teams, focusing on transformational opportunities for savings. I'm sure we'll come on to that later in the agenda. The risks that were associated with this paper are now actively being transferred where appropriate to the CRR to ensure that there continues to be oversight of those risks. There are gaps in senior posts, but we are interviewing tomorrow for some interim support, and indeed there's been some expressions of interest internally. Within the document, you will find that we are actively recruiting for substantive posts, and they are, I think, outlined in table 2, page 5. The partnership working is being strengthened by both the delegation changes in the SWORD and the approach that we're taking in terms of wider decision-making approach with the implementation of the Health Board leadership team. This will ensure that we're having the conversations in a single environment that lead to partnership working and enable swift decision-making in order to support partnership working locally. I am happy to take any questions, but I'm hoping that they do cover the most salient points. I can see John's got his hand up.
He has. John.
Thanks, Mark. Thanks, Jill. I think generally my concerns are around the risks in the implementation of this. In Appendix 2, on page 7, I think it is, it talks about the risk and risk appetite, and it says staff are encouraged to integrate risk management. And for me, that should be an expectation, not an encouragement. We've got a risk management strategy that everybody's supposed to follow. But then in the risk log, there's real concerns for me in terms of that risk log in total. It felt to start with there was a column missing, but maybe the name's wrong because it says impact at the top instead of risk. But then the mitigations, I don't think, clearly demonstrate what is being done to minimize the risks. And I would want to try and get better assurance that those risks are being managed in the right way.
If I may answer, Chair. So can you hear me, John? Sorry.
Yes, I can hear you.
Sorry, I just had something come up saying I was temporarily muted, so it just made me a bit nervous. In terms of, if I can take the risk log first, John, that's exactly why the work is currently ongoing to transfer these risks where appropriate across to the corporate risk register so that we can ensure that we've got continuing oversight of them and that the mitigations are in place, and that will obviously go through QSC as part of the board committee structure. In terms of the point that you make, which I think is one that is very well made regarding the word encouraged, I do want to reiterate that this does align, is intended to align with the risk management strategy, where absolutely it will form the backbone of the operational and the governance structures for the new operating model. So I take that, John. I think it's a point very well made, and we'll make sure that that is reinforced, that it's not encouraged, it's expected.
All right, thanks, Jill. I think just to come back on the risk log itself, given that earlier on we talked about the model for transformation that's embedded in that is MSPs in managing programs, that defines how risk logs are put together, and we should be looking to try and use that structure that we put in place to help manage any program of implementation such as this. And it would help enormously, I think, in terms of trying to construct the risk log and its translation into the risk, the overall risk management for the organisation.
Point taken, and I'll work with the teams on that.
Thanks both. Molly, did you want to come in on that point? Molly?
Sorry, Chair, my IT just paused for a second. Yes, I was going to say that there is actually a risk already captured as part of the corporate risk update. And so that is considered to be the most significant risk on the operating model. And that is around the gaps in resourcing. And so there are 3 more risks that will be added. And we considered them very briefly at the May workshop on the operating model. So I just wanted that to be noted, just for clarification.
Thanks, Molly. Lucy?
Thank you, Chair. A couple of comments on specifically on Appendix 2. So the section there on the executive delivery groups, and in terms of then some of the subgroups that sit underneath the committee, I'm not 100% confident at the moment that we haven't duplicated some of the work here. So I suppose my question is, how can we have assurance that the executive delivery groups aren't going to duplicate the work of some of the other groups, and that we end up then duplicating? I'm really conscious about the number of meetings that take place across the health board, and we need to be working efficiently as well as effectively. And an example of why I asked this question is actually from one of the terms of references for the executive delivery group. It includes assuring the executive leadership team on the development, implementation and effectiveness of strategies. Shouldn't it be the role of the board and the committees on the development of strategy? So I just want to make sure that we've got those very clear lines. And then the second point was around the section on page 9 about partnership governance. That I'm not convinced that's workable in terms of it's the section C under that part about getting authorization in writing prior to a meeting. That links in, I know, with the sword discussion that we had before, but it just seems, the way it's set out, it seems very bureaucratic.
Thanks, Lucy. Joe?
Thank you, Lucy. Of course, setting the strategy for the health board is the purview, quite rightly, of the board. The work of the executive delivery groups is intended to ensure that as those strategies are developed and worked up for presentation and sign off at the board, we take the opportunity to make sure the interlinkages, each strategy with each other, are fully put in place. So it's not to replace at all the work of the board, but seeks to enhance the oversight of strategy work as it is being developed. With regard to your second point about perhaps overly bureaucratic governance. I'm very happy to take that back, particularly in the context of work that is currently being developed with regard to our representation as a health board on RPBs and assorted meetings. Thank you.
Thanks. Just on the same point, Joe, I just think we've got to be aware of the risk that the EDGs are shown as reporting into your wider leadership team, which of course is fine and a matter for you, then straight on into board. There will be occasions where, subject to what they're considering and what they're wishing to report to board, that will be inappropriate, and we ought not to circumnavigate the committee structure.
Totally agree. That's absolutely not the intention through that process. And if we can clarify that through the documentation, we will absolutely do that. There's a proper procession through committee to board of strategies, and that's very, very important. Thank you.
Thanks, Joe. Jill.
Just picking up on Lucy's point around the partnership working and the wording within the document. I think it's clear within the statements that we've made regarding the SWORD and the leadership team that whilst the wording here is clumsy, and I absolutely take that on board, the intent is to strengthen partnership working and enable, not to disable. So I'll take that away.
Thank you. And final point, John G, from you, and then I'm going to close this item down.
Okay, just a quick one. In relation to the strategic overview and the developments, that all seems, it's going its particular pathway. But in terms of the people that we're supporting, i.e. the patients and the public, can I just seek clarity as to how long we actually anticipate it will be before any significant change would actually occur at that level? We're doing the top heavy management, but when will it actually filter through to improvement to service delivery? Thanks.
Joe, then Jill.
Thank you, John. We're already starting to see very green shoots. And a very practical example is with regard to some of the operating arrangements with regard to services in support of the ED at one of our main hospital sites, where those services for historical reasons have previously been provided by the area team and have not been open for as many hours as we would have wanted, and are now more regularly opening, particularly over the weekend. So we're already starting to see some very green shoots whereby looking at services from an integrated health community is starting to make a small difference. It is obviously early days. The structure is designed with design principles that are focused on three individuals, Bethan, Bronwyn and Wahid, two composite members of the public who are patients, and one composite staff individual designed to represent the requirement of the changes to drive improvements from a patient, public and staff point of view. Thank you.
Okay, thank you. Jill's hand has been lowered. So are we happy to note that update in terms of the operating model? And of course, we'll be receiving another update at the next board as previously agreed.
Yes.
Okay, right, I'm going to move us on again. Thank you, and thanks for those comments and observations and the responses. we'll move to the committee chair's assurance report. So I'm going to deal with these in the order they are listed. I don't seek comment unless the chair obviously wishes to make a comment or highlight anything in particular. So first of all, Lucy, it's your assurance report of QSE 3rd of May. And then the extraordinary one on the 26th of May, and then the further assurance report on the 5th. So I'll leave you to work out how you want to focus on these 3 reports.
Thank you, Chair. So I will actually just summarise all of the issues with reports rather than go through them individually, and the risks are clearly identified, so I don't propose to go through those. Just a couple of things I wanted to pull out. Concerns were raised again by the committee about learning, as recurring themes are ongoing in terms of fundamentals of care and safe practice. We're still not seeing evidence of the improvement, hence my comment earlier about the improvement and transformation work. As a result of that, the committee have requested that near misses are incorporated in future reports, because we're concerned that there's an element there where we're focusing on the actual harm to patients as opposed to the potential and therefore missing learning opportunities. The committee did not receive the YGC improvement plan as anticipated, but it noted that it was to be received by Cabinet, which had been convened to provide oversight of the improvement work required on the site, and can confirm, of course, that that improvement plan has now been seen and reviewed by Cabinet. There is one matter that the committee have decided to escalate to the board, which relates to the delays in receiving a mental health improvement plan. The mental health service remains fragile, although it has made some progress. The need for an improvement plan was agreed as a result of a number of serious incidents that had occurred within the division. And the committee has repeatedly asked to see the improvement plan. We have now seen an updated improvement plan outside of the committee, but we remain concerned about the apparent difference in approach for the YGC versus the mental health one. Mental health improvement doesn't just sit with a division and needs to be managed as a whole system approach, supported by the health board as a whole if we are to make the improvements required. And although we know that some of the transformation improvement team have been working with the mental health division, we are concerned that it's sitting too much within the division itself to try and resolve, and actually it needs to be given greater attention and greater focus. Thank you.
So on the first point, learning and never events, which, as you say, has been a near misses has been a long-standing concern. Has your proposal around near misses been adopted, Lucy? Are we happy that's been adopted?
Not yet. It's on the next committee agenda.
Right. So Jill or Amanda, or Nikki, who's put his hand up, whoever is the most appropriate person, can I have confirmation that that will be included in the paper's report for QSE?
Yes.
You can, Chair.
Right, thank you. Thanks. And Nikki, sorry, Lucy, you'll continue to keep us in the loop in that regard, and if the concerns persist, you'll let us know.
Yes, I will, Chair.
Okay. I've then got Tracer, then Joe. Tracer.
Diolch Cadeirydd, a diolch I Lucy am I sylwada. Mae Lucy'n gywir, dyma ni'n rhoi papur lefel uchel I QSE a dyma ddim y manylion oedd y cadeirydd isio o'r grŵp. Da ni wedi bod wrthi'n gweithio ar cynllun welliant ar gyfer y gwaith iechyd meddwl. Dwi'n meddwl fod y gwaith yna'n datblygu'n ddel a mi fedrai rhoi diweddariad a wrach fod y prif weithredraig isio rhoi sylw ychwanegol. Da ni erbyn hyn yn cael cymorth gen y tîm trawsnewid. Dwi'n teimlo fod y cynllun sy'n ger broni ar hyn o bryd yn y cefndir a dwi'n cytuno, Lucy, dyda ni ddim wedi rhannu hwnna hefo'r grŵp I gyd. Mae'r cynllun yna wedi cryfhau. Mae yna manylder mawr wedi mynd I fewn i'r gwaith papur. Mi oedd y manylder yna yn y sgyrsiau yn y cefndir, ond ddim ar bapur. Ac wrth gwrs, da ni'n dysgu oherwydd y cysylltiadau o fewn y grŵp corfforaethol o'r gwaith sydd yn digwydd yn ysbyty Glan Clwyd. Wedyn, mi fyddwn ni'n gobeithio'n rhannu'r gwaith ar cynllun yn yr grŵp nesa, ond wrth gwrs yn y cefndir nawn ni ddal ati i cryfhau'r gwaith, a dwi'n edrych ymlaen i cwrdd hefo chi, Lucy, ac hefo Cheryl, ac hefo aelodau o'r tîm trawsnewid, a mynd trwy'r cynllun gwaith na, mwyn wneud yn siŵr fod ni yn taro'r nodyn iawn fel petai, a bod gynnon ni cynllun sydd yn cwrdd â gofynion pawb a'r holl lygyd sydd ar yr cynllun, oherwydd da ni gyd isio gwella'r gwasanaeth i'n cleifion ni ar draws Gogledd Cymru. Diolch yn fawr, Cadeirydd.
You used the word Gabathio, hopefully. I think we're beyond, hopefully, Tracer, given the fact this has now been escalated to the board. There's got to be a clear expectation that the revised plan or a draft of it, having regard to the support for the transformation team, will be presented to the next QSE committee.
Os gai matab felly, Cadeirydd, dwi'n sicr fod gynnon ni cynllun gwelliant. Mi o gynnon ni gynllun gwelliant, wrach fod o mewn rhyw fformat hen ffasiwn, mi o na cynllun gwelliant gynnon ni o'r blaen. Dwi'n sicr fod y gwaith yn ei lle. Be dwi'n croesawu'n arbennig yn yr bythefnos dwytha ydy rhywfaint o'r newyddion da sy'n dod trwodd o ran pobl adnodda bydd yn helpu ni hefyd yn yr adran iechyd feddwl ac anabledda dysgu. Hynny yw, dwi'n gwybod fod y prif weithredwr wedi bod yn gweithio'n agos iawn efo'r IHI oherwydd y sgyrsiau yn Ysbyty Glan Clwyd. Wedyn, dwi'n sicr fod y cynllun yn dod at ei gilydd. Bydd y cynllun byth di orffan, mi fyddan ni'n dal ati i gryfhau, i dysgu, i ail edrych arno fo, ond da ni angen neud hynna wrth gwrs, nid yn unig o fewn y bwrdd, ond hefo'n partneriaid hefyd. Diolch.
Okay, Joe, you want to come in? I'm certain too that my expectation is clear. Mental health has been in special measures for a number of years. It's been in TI for a number of years. We have got to get to the point where a plan is produced and shared with QSE, which provides the assurance needed. That is not a criticism of the mental health division or anybody else. It's a question of expediting what's required with the support that's available, including the investment we've made in the transformation team. So, Joe, with that said, I'm happy for you to comment. We'd also appreciate an update on where we are with the recruitment into the division, particularly at the senior level. Joe.
Thank you, Chair. Just to confirm that we are absolutely committed and have been committed to ensure that our mental health improvement plan is produced to the same standard as the improvement plan for YGC. And we will ensure that where we have corporate priorities for improvement, they will be mirrored where it is appropriate to do so within the mental health plan due to be formally presented at QSE for all of the reasons, Chair, you have outlined. Perhaps in private session I could give an update on recruitment to the post that you mentioned. Thank you.
You certainly can, Joe, on the second point, but I don't see why in public we can't be given assurance that recruitment is under consideration and indeed is progressing.
You can be given that assurance that recruitment is under consideration and is progressing.
Thank you.
Thank you.
So just to confirm, we are expecting the mental health improvement plan to be presented to the next QSE committee. Yes? Tracer, yeah.
Bydd, mae'r gwaith wedi symud ymlaen. Mi oedd na gynllun tro blaen, ond ofynwyd fel rhan o'r sgwrs am fformat gwahanol. Dyna nathon ni golli rhywfaint o manylion. Mae'r manylion yna ag erbyn hyn wedi cryfhau ymellach, Cadeirydd.
I feel as though I'm not getting a straight answer to a straight question. Can someone confirm a revised improvement plan will be presented to the next QSE committee meeting? Yes or no?
Bydd.
Yes, thank you. Thanks very much. Okay, right. Shall we move on from QSC's updates from Lucy to the Targeted Intervention Improvement Framework Steering Group, which is you, Jill. Again, anything you particularly want to wish to highlight?
And don't particularly want to highlight anything, just the work that's going on behind the scenes, Mark, in terms of reflecting the points that Jo made in her opening statements regarding YGC and the split of the performance and planning elements here. We're also taking the opportunity to review the arrangements of scrutiny around the targeted intervention evidence, Mark, and the scoring, which we will, of course, be working with our IM colleagues to test.
Thanks, Jill. So next is Remuneration Committee, which is me. Molly and I have agreed the assurance of reports that you've got and the matters listed in there. There is nothing I wish to highlight at this point. On to PPPH. Nikki, Linda, anything from you?
Diolch yn fawr iawn, a hapus i ateb unrhyw cwestiynau. Yr unig peth oedd y cyfarfod o'r pwyllgor eisiau tynnu sylw'r bwrdd oedd cytundeb i cynnal sesiwn ar y cyd gyda pwyllgor perfformiad, arian a llywodraethiant gwybodaeth ar recrwtio, a mae'r trefniadau yn mynd yn ei blaen. Diolch.
Thanks, Linda. So that's taken care of two of those reports that are listed. Thank you. So we'll move on to HBF. Oh, sorry, put your hand up. Sorry, I won't move on. Nikki, come in.
Okay, so with regards to Triple PH meeting on the 13th of July, I'd like to bring a matter for escalation to the board, and that is specifically the non-delivery of the asset management strategy, which was previously known as the estate strategy. There's been non-delivery of this for the past 14 months. It has been promised ahead of the October Triple PH meeting. However, given that it has been promised on a number of occasions over the past 14 months, we would like to request that the Chief Executive provides assurance that the strategy will be issued ahead of the October meeting. And alongside that, that there is a clear timeframe of delivery, taking into account the committee's request that this also incorporates a robust assessment of the impact of the delay on certain strategies, for example, the clinical service strategy. We also request consideration in the future that if there is non-delivery of key documents, that it will be escalated to the Chief Executive and Board following one instance of non-compliance.
Joe.
Thank you. Sorry, I couldn't get off mute. I'll take your question on notice, Nikki. I don't want to give an assurance that we will be ready in October if I'm not assured myself. I would like to make sure that I can be very clear about that. Thank you.
What about Nikki's other points in terms of escalation, Joe, towards the end there? Repeated, she'd expect an escalation mechanism to be in place, which includes the board.
Sorry, I've no problems in that escalation once I'm sufficiently clear myself about timelines. And just to note that one of the challenges around the timelines associated with the asset or estate strategy is the interrelationship between the clinical services strategy, which we have just today signed off. So no problem with the escalation point, but let me come back to you, Nikki, with my own assurance on timeline.
Thank you, Joe. And in the committee, we did discuss that perhaps sometimes people offer a deadline date and that's not realistic. So we do acknowledge the point you've made.
There's a further point, Joe, that I seek assurance on. I can see Sue wants to come in, and that is the fact that in deliberations around the operating model and certain agreements reached about senior positions in the estates infrastructure team, we did seek assurance that those decisions would not impede the work to be undertaken around estates and the strategy. And yet we find ourselves in this position. So in providing assurance, I would seek assurance from you at the point that you provide it, that actually the concerns that were articulated at the time within the remuneration committee have now not come to pass.
I will provide that assurance. All of the individuals who we're familiar with remain in post at this moment in time, and that has not been a factor in delay thus far. Okay, thanks, Joe. And then so Molly, can we pick up the last point? This is not just about escalation protocols in terms of the estate strategy. It is about the fact that if there is a prolonged delay in seeking agreement on documents that are due for delivery, that we have a mechanism by which to escalate it.
Yes, thank you, Chair. I will do it. And I just also ought to raise that the committee also considered that in some cases it does impact on the effectiveness of that committee and its cycle of business. So it's part of the assessment. I'm just proposing to do that together.
Thank you. That would be helpful. Sue Hill.
Hi, Chair. I just wanted to note that there is an update on the estate strategy in the capital report that we will be discussing later on in the agenda.
Yeah, there is. I just think we need confirmation, don't we, that the update you provided in that report is going to be complied with, for want of a better description.
Yeah, it is.
Been solved. Okay. Yeah, you're right to highlight that soon. I had noted it myself. Okay, John C.
Thanks, Mark. Fully endorse what Nikki was saying. I was going to make the link to the capital report as well, but on the basis that there's a real disconnect, because the capital report implies that the estate strategy was due in March this year, and whilst also still late, that doesn't line up with what PPPH's expectation was, and the fact that we've been asking this for a long time. So there's a fundamental issue between what the capital report and maybe how that's produced as what their expectations were in producing the estate strategy and what the committee's expectation was.
Yeah, I agree. And the joint position or agreed position should be clearer next time. So we're all agreed about what's going to be produced and when and why, if there is a delay, why that delay has occurred. And I think that's what belies this conversation. Sue? You're on mute, Sue.
Apologies. I just wanted to give some clarification to John's query. The estate strategy was approved in 2019 and was not due to expire until March 2022, when it should have been refreshed. So we did have a valid estate strategy in place. It's just it expired in March. There was an expectation that we would have a revised version before then, but it's the technicality of the actual strategy that we had in place.
Okay, noted. Thanks, Sue. Richard.
Thanks, Mark. I think the connectivity between the estate strategy and the capital programme has been well made, and it is very valid. The two are inextricably linked. But I think there is also a linkage which needs to be highlighted, and that's back to our earlier discussion about the IMTP. I made the point there, and I think people agreed that the estate strategy needs to be reflected, or the development of the estate strategy needs to be reflected in the development of the IMTP. To my mind, we should have a 3-year estate strategy, which is updated each year. So it refreshes each time we go through the IMTP and budget iteration cycle. But I think that linkage is something that we should bear in mind with the IMTP.
Thanks, Richard. Sue or Chris, do you want to respond? Sue.
Yeah, thank you, Chair. Yeah, thanks, Richard. I'm happy to just check in with Chris that we make sure that they are all aligned. I guess the point about the estate strategy is that all of our strategies are inextricably linked. And, you know, obviously they will all have an impact on each other. So the clinical strategy is obviously a key strategy for the board that has an impact on every other strategy. And it becomes a continuous loop of improvement, doesn't it?
Yeah, it does. Chris?
Exactly as Sue said, I think it's a helpful suggestion. I'm sure that there's an easy way of factoring that in more visibly and being really clear that the two are in lockstep. So I'll pick that up with Sue.
Thank you. Right, I'm going to go back to the assurance report. So HBF was next. Anything to be highlighted around the HBF report or any questions in that regard? I'll then move us on to SRG. Claire, anything from you?
Thanks, Chair. Very briefly, I was absent from the meeting. Actually, there were 3 main areas of discussion: the planning update, the clinical services strategy, and partnership approach. I think perhaps the important thing just to make all board aware of is that we're currently planning to hold an away day in the next few weeks to look at how we strengthen representation at the SRG and how we encourage better attendance from some of the key partners that are already there. So in view of that, Mark, the chair, has written to all local authorities asking whether or not the meetings are on the right dates, who the latest nominees might be, so that we can engage effectively with them. So I'm hopeful that by our next board meeting, I'll be able to report back on the outcomes of the away day and how we hope to improve stakeholder input and representation. Thanks.
Great, thanks, Claire. So and then we move on to PFIG. John, anything by way of exception from you? Sorry, no, we don't. We do audit first. Sorry, apologies. Medwyn first, and then John. Medwyn.
Diolch, Mark. Diolch, Cadeirydd. Prynhawn da. Dwi'n cynnig bod ni'n derbyn y papur fel mae wedi cael ei gyflwyno I ni fel crynodeb o'r cyfarfodydd ar y 10 o Fehefin, 30 o Orffennaf ar yr ail yr 20 o Orffennaf. O safbwynt materion oedd angen uwchgyfeiriau'r bwrdd, cytunodd y pwyllgor I ddwyn sylw'r bwrdd at yr adroddiadau sicrwydd cyfunedig sydd wedi rhestru o fewn y papur, yn ogystal â sicrwydd cyfunedig y pennaeth archwilio mewnol ar sicrwydd ar gyfer blwyddyn ariannol 2001-2002. Da ni wedi trafod y sod, da ni wedi trafod y strategaeth rheoli, ond yn ychwanegol, cytunodd y pwyllgor I dynnu'r sylw'r bwrdd at ein pryderon ag anflodronrwydd ynghylch y sefyllfa o ran cyfrifon ariannol 2001-2002. Mae yna crynodeb mwy manwl yn rhan sicrwydd allweddol o fewn yr adroddiad, a dwi'n siŵr fydd yr cyfarwyddwr cyllid ag Prif Weithredwraig eisiau ymlaethu ar hyn am bellach nes ymlaen. Diolch.
Joe or Sue, is there anything further you want to say at this point, or do you want to wait for the financial update to do so? Joe.
For the financial update, please, Chair. Thank you.
Okay. But Medwyn, the point that you seek to, or indeed you do highlight about the number of limited assurance reports, and you list them in your assurance report, where do you now stand in terms of your concern about the number of limited assurance reports? Have you received any assurance that you feel you need, or do we need to discuss that now?
It's still work in progress and we still need to discuss it, but I think there are 15 and we've not been in this position for over 3 years. That's my reading of the situation. So the situation is not getting better, it's getting worse at this moment in time.
So, Joe, your response to that concern?
Thank you, Chair. Thank you, Medwin. Yes, we've noted, more than noted, the numbers of limited assurance reports and put a series of processes in place that are designed to ensure that we are dealing with matters of timeliness of response. And I think you would acknowledge that those matters have improved, and to make sure that we're working more closely with our colleagues in internal audit on the matters with regard to the audit plan. It's always my intention as we work through our audit plan to select issues for internal audit that have a link to our assurance, governance and clinical risks. And of course that may mean we are quite appropriately, in my mind, shining a light on areas which do require, or which subsequent to an internal audit report will require actions as a result of a limited assurance report. Thank you.
Lucy?
Thank you, Chair. I'll be very succinct. The point that I made about priorities earlier, I think, is becoming more evident. Can we have assurance, please, from the executive team that they are going to look at the priorities again to make sure that we are actually using our resources in the right areas to address the problems that we're dealing with at the moment, which unfortunately seem to be escalating?
Joe?
Yes, one of the pieces of work that we have done most recently is to review with internal audit our plans, our audit plans for the year, to ensure, precisely to Lucy's point, that our audit plan is more reflective of the long-standing and emerging risks that we're working with.
Okay, and can you keep the voice cited on that then, Joe, given the concern that exists?
Yes.
And the number of limited assurance points is obviously, reports is obviously due to be discussed at audit again. I would invite you to ensure that your representatives at the audit committee are focused on the number of reports and what we can do to ensure that the limited assurance numbers decrease rather than continue to increase. Medwin, if there continues to be a concern, no doubt you'll escalate it.
Yes, I will. Thank you, Mark.
Thank you. Right, so they are the assurance reports. We're now going to move on to performance and delivery. And the first item is the integrated quality and performance report, about which, Sue, you will have seen I've already articulated a number of concerns. Over to you.
Yeah, thank you, Chair. So I think I need to just pause and acknowledge the challenges we've had around performance reporting at the Health Board, particularly since I took on responsibility for it last October. We have done an awful amount of work trying to get a document that the committees and the board can both use. We've tried to use data in a different way to make it more interactive, and by using the SPC charts, looking at how we can make data count and making an interactive report. Mark, I have noted your really constructive comments about the issues that you've found with this current version of the report. And I guess what has come to light in that, trying to be a bit more advanced and ambitious in the way that we manage our data, trying to get that into a hard copy report for the board has caused some key issues around the way we use the report. The report is an interactive Power BI report that you can click into, and obviously we can't have that working through IBAB. So I have had a conversation with the team. It's been a collaborative piece of work between the ICT team and the performance team, and we're going to put in place a more robust review process. And obviously this is an ongoing cycle of continuous improvement for the report as we try and get it right, and then make sure that we are taking on board the comments of the board and committee members. I guess where we are is it feels like an unfinished report, an unfinished development, and I apologise for that, because obviously we have been trying to get this right for a long time now, and obviously the committee chairs have been really instrumental in getting us to a place where we at least have made some progress, which I think can be evidenced by the report. I think we are definitely moving in the right way. But you've made some really valid points, particularly around things like the 12-month trend and the fact that the narrative isn't clear which measure it's referring to, and that is something that I'm going to have to pick up. And I can only apologise for that. But I do think that we are making huge progress. It's just it's taking us a lot of time, and it's quite a painful process. And before we go into the details of the report, I'd just like to pause there in case I've got any questions, or Mark, you want to make any specific points about the points that you raised. Just one thing though, in terms of the data being 2 months old, that is because we try and ensure that the report has been scrutinised by a committee before it comes to board, but obviously it wasn't in this format, which makes it a bit difficult. So we can definitely do something about it, making it more timely, but we won't be able to have that scrutiny through the committee.
Right. In which case, if we're relying on data that's relatively old because it's been through a committee, then I would expect there to be some description of the issues considered by the committee in question and the actions agreed to. Otherwise, we've got the platform for assurance.
Yeah. Okay. What we have agreed is that the measures in the report will be governed and monitored by the PFIG committee. So if the board and yourself are in agreement, Mark, what I'll probably do is have a meeting with John outside of the board to agree how we can make the data more timely, whether there is something that we can do to fast track that process. So one, we're not looking at data that is now 2 months old, but two, to make sure that we are just picking up on all the points and we have a constant check in place. And I think what I'm going to do is put in place a sort of a working party that takes feedback from the committees and the board and make sure that it is updated, and there is probably a narrative with the report in the cover sheet that explains what measures we are taking to improve the report as we go through it.
Okay, so can we agree that you'll respond to the comments I've made about the construct of the report outside following the conversation with John, please?
Yeah, yes, of course. Thank you.
So we'll turn our attention to the performance described in the report.
Okay.
So any headlines you want to make, Sue, before I open it up to colleagues for questions?
No, I think it's given that we're running a bit late, I'd be happy to take questions first.
Okay, right. Questions in terms of the performance described in the report, please. Lucy.
Thank you, Chair. I find the narrative in the report actually really confusing. I don't think it is clearly laying out what we need to know in order to get assurance over things. So then if we go to page 13 and then page 14, that just looks like the same narrative from the page before. And we've basically gone from what was supposed to be achieved by the business case in what are the key issues and drivers for why performance is where it is, to then going straight into a note list of the reasons why the business case has been delayed, etc., etc. And I'm not quite sure what, I just can't make sense of it. It doesn't flow. And therefore, I'm not assured as to what's actually being done to address what the issues are. And I'm not sure what part of the actual performance that the narrative is trying to address.
Yeah, thank you, Lucy. I mean, that is one of the points that Mark made. I think what's happened is that the narrative is picking up on only specific measures, and obviously with it not being titled, that is not clear. But equally, I think if we look at it, what's happened is it's a duplication effectively, because you've got the narrative from March and the narrative from May over one measure included in the report. So that is something that I will address. What I will suggest, if the board is comfortable with that, is that we will reissue this report to the board, making sure that it's got the full detail in it.
Yeah, yes, I think we need to do that.
Thank you.
Claire.
Thanks, Chair. Probably some similar points, really. And I realise this is a whole new system, isn't it, which is going to take some bedding in. I think one of the things that would be really helpful is a kind of review around what I kind of call the wood for the trees, because 71 pages, and when I look through it, I think some things are fundamentally board member issues and board member areas to review, but I think some things are in the committee domain. So I think we do need a refresh on that, because it was really hard. If I was to ask some questions now on performance and actions we're taking to improve in areas where we've got concerns, which is a lot of them, we'd be here all day. So I think it's really hard to kind of get a grip on what are the key things as a board that we are interested in and need to know, because they're fundamental in meeting all of our key strategies. And then I guess importantly, where we're not hitting targets, what are we doing to improve and address them? And you really can't pick that out of the report at the moment. So sorry, it's more general comments, but I feel it's hard to be more specific until we kind of get the report working a bit more effectively for everybody.
Yeah, thank you, Claire. That is helpful feedback, and we'll make sure that we reflect that in the next version of the report.
We may need to have a workshop,
yeah,
and this is the topic for conversation, which is something John suggested in the chat bar. I think we're going to need that. I've got another topic I think we need to discuss in terms of workshop, which I'm liaising with Joe over. So that might be the plan. But in the meantime, if you can recirculate the report,
yeah,
that'd be helpful. Can I turn then to substantive issues that are highlighted in the report, and that is the scale of underperformance or performance concerns that are listed and described in the report, which are no doubt a concern to all of us and will be of real concern to anybody viewing this report independently of us, and understandably so. So can I first of all turn to unscheduled care and where we now stand in terms of the unscheduled care improvement programme, and particularly the initiatives underway at YGC in that regard, and particularly as regard the emergency department. So who is in a position first of all to talk about that? Jill. Jill?
Oh, yeah, apologies, Mark. I couldn't get the mute button off. And I'm sure colleagues will come into support. So in terms of unscheduled care, absolutely, we're focusing on YGC, but not exclusively focusing on YGC as you would expect. But what we are doing is using the YGC improvement work, and indeed the offers from Improvement Cymru working alongside us to further define the improvement measures that we will be bringing back to board, Mark. And if I can use an important example, one of those is clearly around our ambulance waits and ambulance handovers, because that has an impact across the whole of the healthcare system, particularly to people who are waiting at home potentially for an ambulance. But it does also reflect the work that we are doing to alleviate the pressure on our beds. And you'll have seen in the BAF that we currently have a significant challenge with patients who would be better served elsewhere. I think we've got 249 currently medically fit for discharge patients across the health board. So I've alluded to the work that we are absolutely doing with partners to expedite that, including the point that John made earlier, John Glanders, sorry, regarding getting people home to assess them, because that's the best environment for them. But also doing work to see what we can do to purchase some care home beds as well in order to support that discharge and alleviate the pressures at the front door. So yes, we've got the improvement plan. We also have defined an unscheduled care group, which will be chaired by myself to ensure that any unblocking that is required in order to progress some of these initiatives is taking place, but we're also monitoring performance, and I'll be doing that through the operational meetings as part of the new operating model as well, Mark. So absolutely work is taking place. I think the measures that we're incorporating, I'll pick up outside with Sue H to ensure that we incorporate those moving forward as well, so there's strong visibility.
Thanks, Jill. So then can I just take us to planned care? The same applies. We're also been set targets by the Minister in terms of planned care recovery. We know those targets are challenging, but at the moment our performance is showing no sign of improvement, really. So in terms of the organisational response to planned care and where we are, Jill, in terms of our improvement programmes.
Yeah, I'm happy to give you headlines, Mark, and I would also like to say that Chris's team are working very firmly alongside us or on that transformation piece, and you'll have seen some of the work that was highlighted in the earlier document. So we have worked with the delivery unit to refresh the profiles for our planned care in line with some recommendations that they have made, and they are now happy with the work that we've undertaken on that. We are currently working to ensure that where we have got, we're risk assessing our planned care opportunities at this point in time, Mark, because we're conscious that we have previously heavily relied on contracts outside of Wales for some of the activity, and we need to risk assess that in line with the pressures in England as well as within Wales. We are looking at what we can do to encourage, and it is in the report, encourage more non-face-to-face, so virtual consultations, and that is being refreshed as we speak, working with colleagues, and I think we do have a strong planned care recovery, albeit it's not going to get us to a position that we would wish to be. The other point I would make is we're working in conjunction with the Welsh Government colleagues to see what we can do to pilot some of the virtual assistance that's available to us to validate the list. The other point I'd make is that, and Joe may wish to make this, but the work we're now doing within orthopaedics and the seen on symptoms and patient initiated follow-up, we are progressing quite significantly, and that has meant that I think our orthopaedic plans moving forward have been seen as really aligned to the work that we're with the girth proposals by Welsh Government. So I think that whilst we have had to do quite a significant amount of work most recently, Mark, what we are seeing now is progress, and some of that will be discussed more broadly in PFIG later in the month.
Okay, thanks, Jill. Sue G, in terms of the workforce measures, sickness is the one I want to focus upon. It refers to sickness being at its highest level of the sickness rate in the last 12 months. How concerned should we be about that, Sue, and how comfortable are you with the responses that are in place?
So I think we should continue to be confirmed whilst it was forecast, particularly post-COVID. And of course, we've gone through further waves of COVID. So COVID sickness absence is going up and down, but the indirect impact of COVID is definitely having an effect. How confident am I? So I am confident that we have the staff wellbeing and support services in place. We've expanded those through the course of last year and through the course of this IMTP. In terms of managers' capacity to really focus, as I know they would want to, on proactively supporting staff both in the workplace and whilst absent, I think we've got more to do with that as we move through the revised operating model and move through the revised people operating model. I think I will be more, I know I'll be more confident that we've got a really strong grasp of making sure that we're supporting staff through all of the stages of their sickness absence. The measures that were in place around supporting staff who are absent with long COVID are coming to an end. Some have come to an end, some will continue for a couple more months. And I think that gives us a bit of an indication of what we're seeing nationally, that there has been a view that we needed to extend that given the amount of staff that are suffering from long COVID. But we'll continue to do what we have been doing, continually reviewing the trends and the hotspots. I think as we bed in the operating model and then the people operating model, that will significantly support our infrastructure to manage more proactively.
Okay, thanks, Sue. Thank you. And then in terms of mental health, Lucy, Teresa, can I have some confidence in the fact that you two will be, no doubt, in your regular conversations discussing mental health related performance and the impact the improvement plan is likely to have on those performance measures or not, as the case may be?
Yes, we will, Chair. And in fact, it's the subject of regular conversations with the Minister as well.
Thank you. Teresa?
Diolch. Ac os da chi'n edrych ar y ffigurau perfformiad, wrth gwrs mae gynna i rei o'r ffigurau fwy diweddar, a da ni'n dal i ddangos cynnydd o ran rhan 1A, A, B, a hefyd rhan 2 o'n perfformiad ni. Da ni'n gweld gwelliant. Diolch yn fawr.
Thank you, Teresa. And then, Joe, I mentioned earlier on that I thought we might need a workshop to discuss the particular topics. I think we ought to discuss the performance report of that workshop if colleagues are happy for me to arrange one. But the second topic that I'd like to discuss is, and given the useful information you and others have provided on sustainability, is primary care sustainability, the accelerated cluster development programme and such like, and Lucy agrees. So Joe, if you're happy, I'll get the office or get someone to arrange the workshop at a convenient date.
Yes, good idea on both fronts, no problem. Thank you.
Thank you. Thanks, Joe. Okay, so I'm going to move us off of that item onto the annual plan monitoring report, which is listed for you, Sue.
It is, thank you, Chair. So as agreed and as noted in the action log, this is the new format and content which we said we would bring as a proof of concept to the Health Board. The report is based on feedback we've received and is linked to the specific actions that we've got in the IMTP, which is now an annual plan for this year. We've tried to sort of match the style and content of the IQPR. So we've tried to split it by chapter. And then what we've tried to do is make sure that we have got an update on only the red measures to date. I have noted your comment, Mark, about the ambers. There's a number of ambers that are sort of being tracked, and we probably need narrative on those to stop them becoming red. But I'm happy to take any comments, and I can see there are a couple of hands raised already. There are a couple of areas that we haven't got outcomes included yet, and that is a work in progress with the relevant operational leads, and we will have that in place for the next meeting. Thank you.
Thanks, Sue. Claire, I think your hand is an old hand, unless you tell me otherwise.
I think it is, but I'll come in at the end of after other people. I'll re-raise it. Thanks.
Okay, Lucy.
Chair. So we did have a number of meetings with Sue and her team to look at the this report, and I certainly welcome the format of the report. Unfortunately, the content it's the content that's problematic, and the difficulty that I have here is that we had the various meetings we had about this report. We got a mock-up with no content in, and so whilst we agreed the format of it, what we've got in front of us, I'm afraid I still don't consider to be fit for purpose in terms of giving the board assurance on how we are progressing against the annual plan. And the reason for that is that the programmes that are listed on each of the pages, they are just so high level that we've no idea what it is actually that is being progressed. And I appreciate you say that, well, there'll be a drill down, but that's not what we've got at the moment. So, you know, we've got a programme of urgent primary care centres, stroke service, but what exactly, when you're then telling us whether it's been completed or it's on track, we don't know what is completed or what is on track because there's nothing here. Whereas the documents that you sent through to us on emails actually had some of that information in there. So what was described to us in the documents, it wasn't at this very, 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 very high level. It was much more descriptive, yes.
Yeah.
But the other thing I'm really concerned about is here we are well into Q2, and we still have no outcomes for a number of these programmes. Whereas I thought we had outcomes actually specified as part of the IMTP process. So why haven't they been lifted and put into here? And the second thing is where the outcomes, where we do have some outcomes, they don't seem to directly relate to the actual programme that's being described. It just seems to, forgive me if I've got this wrong, but what it appears to do is just drop in something that we've been able to measure as opposed to an actual outcome that is directly applicable to the programme that's being described.
John, Chris to come in first, so just put his hand up, share the load. Chris?
Yeah, thank you, Chair. Yeah, thanks, Lucy. Just to be fair, whilst Sue's reporting on this because the performance team report upon the performance against it, my team have been heavily involved in supporting Sue's team in pulling it together. I think the point you make in terms of the depth in which it goes to is really helpful, and I think that's something that we can easily address. But just to be clear today, the references within it and the points that are being reported against are exactly those that featured as part of the 3-year board approved IMTP. So that detail has been to board, albeit that it's not explicitly referenced within here. So these aren't new areas. They are reporting against what has previously been, but I think we can pretty easily improve the presentation of it, and we'll take that away and work on that as two teams working together.
Thank you. I think that would be helpful. I think a key point is, isn't it? So we know what we've got in the plan. You're right, Chris. We approved it. If something's off track, what is it actually that we agreed that is off track? And can we be clear about that and what we're seeking to do about it? The two things ought to be naturally linked.
We can do that easily. Yeah.
And I think the second thing is, and it's Lucy's point, on the left, we've got some outcomes listed. I think we made some endeavour in that regard around the IMTP. So let's not put things on the left if they are not things that we previously agreed or are not agreed before we get to this report. And if we are going to include some of the things on the left that are included in this report, then it is naturally going to lead to some questions, which I posed in my email, didn't I? In terms of, well, on the one hand, we've got actions in the reporting being shown on the screen, but actually some of the outcome measures on the left are declining. So why are they running counterintuitively? At the very least, there ought to be an explanation of that fact. Yeah.
Absolutely. I think we can address all of those points quite easily. Thank you.
Right, and then just before I come to Claire, there's one specific point I'd raised, and Nick, I'd welcome a response from you on this point, and that is the item in red which concerns diabetic foot pathway. A matter of some concern, some history, and the update describes how progress has not been made since January as the programme requires release of funding. Then go on to talk about slippage. I can't, from reading that, understand why it has not progressed and whether the slippage is likely, and I hope it is, going to provide the opportunity to do whatever it is that's been required and described in the plan. So Nick, where are we in that particular matter?
So in terms of governance and pathways, all the pathways are now approved. Appointments to posts is now beginning. Indeed, one panel was held about 2 weeks ago, looking for a consultant to take some of that work forward. There is some further work that is being done, Chair, in order to finalise the composition of those panels, and further adverts being out in due course. So there has been some slippage, but we're now back on course.
Thank you, Claire.
Thanks, Chair. I think I'm wondering whether we could be looking at the annual plan alongside the IQPR, the performance report we've just looked at, because one's extremely detailed, 71 pages, and this one's extremely high level, and yet some of the same topic areas are referred to, so it's quite confusing. So unscheduled care is marked as a green in the annual plan, and yet there are loads and loads of reds on unscheduled care in the performance report we've just reviewed. So I'm just wondering whether it might be appropriate to kind of consider the two things together, because they are fundamentally related.
That is certainly why they are listed alongside each other. But there might still be a better way to choreograph the conversation, for want of a better description, and it's worth considering. But that's why they sit together, Claire, with that point in mind. And I haven't today, I normally move between the two. But we can again consider that. Joe?
I was just going to say that they are related, but they're not the same. And as Mark says, there is some complexity. So I would suggest that we consider how we can we think about the two when we look at our board workshop, Chair.
Okay. Yeah, thank you. Let's do that. Right, I'm going to move us on again, and Sue and Chris, look forward to you doing the work that's required to respond to the observations made. Thank you. So we come on to people and resources, and we come on to the finance report. And Joe and Sue, you've had notice from me, but if there's and there are many documents today that have caused me to give rise to or raise concern, but this is at the heart of them. In terms of what this report tells us and the assurance it provides or not, as the case may be. So, Sue, are you handling this report, or is it Sue, you and Joe? How's this being handled now?
Thank you, Mark. If I start off, but before we go into the monthly performance, I just wanted to comment on the draft accounts for 21-22, if that's okay with you.
Of course, yeah.
Okay, thank you. So with regards to the financial statements for the financial year from the 1st of April 21 to 31st of March 2022, where we are is that the audit is still ongoing, and the Auditor General from Audit Wales will issue a qualified true and fair opinion, because he's been unable to obtain sufficient audit evidence that the accruals, payables and related expenditure have been properly accounted for in the correct accounting period. The current timeline is that we are expecting to go to Audit Committee on the 24th of August and sign that off, at which point the accounts will be laid before the Senate that same week. I just wanted to reflect on last year and give my apologies to the board for the situation that we're in. It's incredibly disappointing. As the board will be aware, we've always had a very high assurance rating for both internal audit and Audit Wales, particularly over the last 3 years when I've been leading on the annual accounts. Effectively, some significant errors were picked up by Audit Wales as part of their initial testing, which made them do additional testing. And I think the errors currently relate to about 9.3 million. I think last year was an incredibly challenging year coming on the back of the pandemic, because for 21-22 we were trying to manage COVID at the same time as do everything we can to recover planned care. And so we had additional funding to do that, both around COVID, around planned care. And unfortunately, Omicron hitting us sort of the back end of 2021 had a real impact on our planned care recovery, particularly because we are so reliant on NHS England providers who were also facing the same difficulties. So I guess this meant that, you know, if we looked at what we expected to deliver both financially and operationally last year against what we actually did, you know, there is a huge issue for the health board. I have reflected on what we tried to do in order to optimise the use of the resource allocation given us by Welsh Government for use for healthcare in North Wales. And I think, you know, there were some errors there that should have been avoided, but I take full responsibility for that as the Executive Director of Finance. And I don't want it to reflect on the finance team, who have done a fantastic job over the last couple of years supporting the health board. But we absolutely acknowledge the errors that were made. And we have put an action plan in place that went to the executive team in June, and we are working through that in conjunction and partnership with both Audit Wales and Internal Audit to make sure that we are able to provide assurance to the health board and to those two independent bodies that we are making sure that we have put in place controls that means it won't happen again. I think the next step is just to reflect on the lessons around what we tried to do last year in terms of delivery, and look at that particularly in light of the financial report for month 3, which I'll go on to now, and the challenges that we're going to have to deliver this year to make sure that we can hit our position. I guess I'd leave the 21-22 there. Obviously, we are still in a draft position with Audit Wales, but we thought that it was right to give as much information as we can now, although obviously we won't have a final set of accounts until we've gone to audit committee with them. So I'm happy to take any questions if there are any at this point before I move on to month 3.
Joe, is there anything you want to add as accountable officer?
Thank you very much, Chair. We had a series of very full and thorough conversations with regard to the audit matter at various audit committee meetings. And I would like to thank audit committee colleagues for the scrutiny that they provided on this very significant matter. As Sue has acknowledged her responsibility, I would remind the board, as I have reminded Sue, that I am accountable as accountable officer for the accounts matter, and it is actually my obligation and wish to add my wholehearted apology to board colleagues for this matter. It's a really unusual situation that we find ourselves in, and as Sue has said, is very far removed from our normal situation. But to assure the board that all of the resources were spent with the health needs of the population very, very firmly in mind. as has been acknowledged by myself and others through the earlier part of the meeting, as accountable officer, I'm obliged to provide advice to the audit committee on the matter of the accounts, which I did do, and the audit committee has accepted that advice. Sue's paper outlines the consequences to us as an organisation with regard to the timelines associated with our annual general meeting and our breach of standing. Therefore, I don't have any further comments at this point in time on the report regarding the audit of accounts. Thank you.
Thanks both, and for the recognition and the policies. A number of recommendations were made by the audit committee chair with the support of endorsement of the board secretary, which included the fact that matters that have occurred on this occasion should not occur again, and certainly not without the engagement and oversight and agreement of the audit committee. And my strong advice is that you adopt those recommendations, because they are there with the best intent made, and also it provides certain safeguards in terms of the governance of the organisation, finances, and the role of the board.
They will all be adopted, Mark, and to confirm, as per our agreement, executive director personal objectives and my own personal objectives will be amended to reflect those requirements. Thank you.
Thank you. Thanks both. Right, so let's go on to month 3 then.
Okay, thank you, Chair. So the month 3 position, as highlighted on the dashboard on page 3 of the finance report, is of a 2.3 million adverse position against a plan to break even. This is a slightly better performance than in month 2, and which was a better performance than month 1. So basically we had a 1.3 million deficit in month 1, a 0.9 million deficit in month 2, so that we've got a cumulative 2.3 million adverse now. We are still able to project a balanced position because we anticipate that we will recover that deficit over the next 7 months. But as has been highlighted a number of times already during the board meeting, the issue is probably around, the main issue is around our savings delivery and our savings pipeline. So currently we are forecasting 13.7 million of schemes against a plan of 35 million, which means we've got a 21 million adverse variance there. There is a comment in the plan about transformational savings. So when we set the plan, we targeted 35 million as a savings target, which we were looking to split 50% transactional and 50% transformational. I guess the point that's made in the paper is that we didn't plan to have any transformational savings in the first quarter, because we knew that there would be a bit of a trajectory to those being delivered. But so I think from my perspective, provided we hit the savings target, whether it's transactional or transformational, it's not as important as us hitting the big number. In ordinary years, i.e. pre-COVID, we have a track record of delivering between 35 and 39 million of savings, albeit not necessarily on a recurrent basis. And then the last 2 years, we've delivered 17 and 19 million respectively. So I have confidence around delivering a much bigger number than we are currently forecasting. But the challenge now is for us to work with executive and operational clinical colleagues to drive that programme of transformational savings. Over the last month, we have had a series of meetings to try and identify real credible savings targets. We understand where the benchmarking is. We understand that also from an FDU perspective. And obviously there's a lot of work going on across Wales with the directors of finance to see where we've got successes elsewhere that we can then transfer it to other areas of the system to make sure that we are maximising our savings. I think from a quality perspective, the biggest opportunity must be around our non-pay spend, because that is something where if we can manage the cost of the goods rather than the volume, you know, we have an opportunity to provide recurrent savings. But that is all something that is in train with NWSSP, so we're working on that as well. In terms of, I guess, the pressures that we're seeing so far in the year, we've got some pressure around agency expenditure, and we've also got pressure around non-pay, particularly around the usual suspects, unfortunately, of drugs, whether primary care or secondary care spend, and around CHC and FNC, which is absolutely understandable given the inflationary pressures that everybody is seeing internationally. They're also hitting our colleagues in care homes. So, we are something that we've got to manage, but we have made significant saving previously around CHC, and that is something that we need to look at. But it's something that we are working through, and obviously it needs the combined efforts of the operational, clinical, finance and transformational teams to make sure that whatever we are doing is aligned with the plans that we have for the transformation of services around value-based healthcare, so that we are maximising the input and output we get from those transformational schemes, and not duplicating so that we've got too many things going on at the same time. Just a little comment about COVID-19. We're currently forecasting 47.2 million of expenditure this year. We expect that will reduce over time, just as the controls in place to sort of do lessen. But that will have no effect on our financial performance, because at the moment we are assuming it's going to be offset with expenditure from Welsh Government. I think this is not where we want to be, and obviously we've had a series of conversations around savings over the years. And if we go back to sort of 2019-20, when I joined the Health Board and we had a turnaround director in, there was an incredible amount of work that went into trying giving us a pipeline. And what we need to do now is put in place the systems to deliver against that pipeline. I guess the risk around that is that there are some elements that may not be deliverable just because of the changes in practice over the last 2 years, which we can't forget about, but we just need to work through it. I guess the only other thing that I would comment on is the risks on the final page of the finance report. There are a number of risks there. Some of them I've mentioned already, so CHC and agency costs. We've got 2 lines there that have the highest values, the 19.6 million for non-programmable COVID cost and the 22.1 million for exceptional costs. Those lines have been asked to be put in there by Welsh Government because of the pressure that the system is under, the national system. But obviously we're doing everything we can to mitigate those pressures at the moment. And obviously we've got a risk of 11.9 million of non-delivery of savings, which is sort of broadly in line with where I think we could get to from a transactional basis, which is at least 22 million, given that we delivered 19 million last year. I'd probably leave it there.
Close.
Chair.
So close, yeah. Thanks, Sue. Okay, I'm going to open it up. I'm just conscious of this time, and that there are other things that we want to say about this report, I suspect. John.
Yeah.
Thanks, Mark. Thanks, Sue. I'll try and keep it brief. As you've touched on, savings is the key issue here, I think. But I think I'm still worried that the mechanisms for generating the pipeline of savings are still there and working. We knew what the target was at the beginning of the year, but the fact that we haven't identified sufficient saving schemes is of great concern, and the fact that we're under-delivering against the schemes that have been identified. That, combined with the fact that we're overspending against other budgetary areas, particularly secondary care and mental health, makes me question whether we can justify a balanced forecast position at the moment. And I think in terms of savings, we have to focus on what can we deliver this year. And I know the bias this year was more non-recurrent rather than recurrent, given the 3-year sort of plan. But should we be doing something in parallel about next year's savings and starting now to try and populate that pipeline so we don't have a similar position at the beginning of next year? I think there was at the last PFIG, there was reference to a meeting coming up on the 7th of July in terms of identifying more savings. And I think you sort of touched on that, but I've got no sense of the quantity of additional savings that might have been identified. Have any additional savings been identified, or are we still in the same position? Because if it is with three months in, it doesn't feel very comfortable in terms of the long-term view for this financial year.
Sue, do you want to respond? You're on mute.
Sorry. Sorry, John, you're absolutely right about the issue that we've got around the sort of the conversion of the saving ideas into deliverable schemes. We've had a lot of progress against that, but it's the bit that we're just struggling to is crystallizing them from being ideas to being deliverable schemes, and that is just about working it through with the operational clinical colleagues. I think Jill's got a hand up, so she might be about to comment on that, but we've definitely got opportunities to deliver the 35 million this year. What we need to do now is just make sure that we can get the PID on the system so that we understand it and we can do the check and challenge around it.
Okay, I'm going to stop it here and intervene, I think. Look, I've made my position clear overnight, and I will restate it here in keeping with what John has just said. I am not assured by this report. The organisation is overspending again and under-delivering again in terms of savings, and by some sizable degree. So I'm not convinced as chair of this board, and I know colleagues of a similar view, that either sufficient financial control is in place around expenditure or that sufficient and robust measures are being taken to deliver the savings required. And so in your point around transactional and transformational, you set the split, which was agreed by the board. So to depart from something that was set by you as Director of Finance and endorsed by the board on a bit of a whim around the fact that I don't care how we're going to deliver the savings as long as we deliver the £35 million is actually out of keeping with what the strategy was that was agreed by the board. And that is not acceptable. So Joe, I want to hear from you what you propose to do with your executive team to address the substantial concerns that exist on this topic, and particularly to provide assurance to the board that actually significant financial control is in place or is being put in place to address the expenditure point, and for example, in terms of some of the particular divisions, but also what you plan to do as an executive team with the rest of the organisation to provide and bring to bear the focus that should have been in place around the savings programme, but doesn't appear to be in place at this point. Joe.
Thank you, Chair. To build on the comments that Sue made, we are working with our provider colleagues to ensure that we have a strong focus both on transformational and transactional savings in order to take us to a balanced end of year position, acknowledging the challenges that we do face. We discussed in detail our requirement to achieve savings across this financial year at our executive management group yesterday, which is a group that consists of all senior leaders within the organisation who hold financial accountability. Our governance and review meetings with individual parts of the organisation are in place going forward, and financial balances, as you would expect, on those conversations. Additionally, as Jill has mentioned, conversations with regard to the importance of both transformational and transactional savings have been held with Teresa and Jill. Obviously, delivering our financial bottom line position is a clear corporate responsibility across the organisation as a whole, for which I'm ultimately accountable. Those two executive directors do hold the majority of our provider budgets, and therefore it's important that we are involving and engaging with those individuals in those conversations, as we have done thus far. We do remain confident that there are a number of transformational and transactional savings that we can still go at. And to remind our colleagues, our forecasting and profiling of transformational services was due to be later on through the year, and certainly our experience to date shows that profiling decision has been the right thing. We've long talked about the importance of maintaining the right kind of financial controls and ensuring that we encourage our frontline staff to identify and implement practical savings proposals, because it's often they who do have the very clear insight in terms of opportunities for efficiencies. I also chair a focused meeting of all executive directors, a monthly focus meeting of all executive directors, in addition to our existing governance processes on the sole item of ensuring financial balance. And that is an additional governance step that we have put in place during the course of the second quarter of this financial year. Thank you.
Thanks, Jo. I'm conscious Jill and Richard have got their hands up. I've made my concerns and position clear, and thanks for that response, Jo. So I'll just check with Jill and Richard if there's anything else they want to add that might be useful to this conversation at this point. Jill.
Mark, if I may, just to re-emphasise that conversations have taken place the 1st of August, so the day the operating model went live, with the teams, and we've agreed the focus in line with the benchmarking report that Sue referred to earlier. So those will be taken forward with a degree of focus across the operational teams, and there will be operational leads working with finance colleagues, workforce colleagues, and the transformation colleagues to ensure that we're driving those forward. And they will be reported upon in terms of progress. So it's just to reassure you, those conversations have already been re-emphasised and reinforced.
Okay, thanks, Jill. Richard?
Thanks, Mark. Can I start by saying I agree wholeheartedly with everything Mark said in his earlier comments. The report is disappointing. We are clearly not in a very good place, and to my mind, what's missing from this report is an underlying message. It's a presentation of numbers and tables, but there's no real ownership of the financial situation. To my mind, what the report should be saying is, this is the situation that we're in now, and it's not a good situation. If we do nothing, we will be in an even worse situation. And here are a list of specifics that we need to be doing and who needs to be doing them. But there doesn't seem to me to be that grasp of responsibility. It's very traditional, very laid back. There will be discussions, we are talking to people, but it's the same old that goes around the wheel every single year. The big thing that's missing, of course, is the savings, as people have said. And our current position on savings is extremely unconvincing. We are way behind time-wise where any other organisation that I've been involved with would be in terms of identifying the savings. And what we've got only partially covers it. There's huge holes, and there's also nothing to indicate how the savings are being generated, how would they then be applied by divisional management across the piece, because unless we do that, they will all be ineffective, and we'll end up once again with accountancy generated savings in the 12th month of the financial year. I do find it interesting, if you look at the table on the divisional positions on page 5, that not only are we overspending, but virtually every single part of the organisation is overspending. The only one of note that is performing against its budget is the central area. All of the other areas are overspending. And I do wonder if it would be beneficial either for this board or for PFIG to get one of the directors, sorry, I don't recall the terminology for the posts under the new operating model, the directors of one of the major areas, such as one of the hospitals, have them come forward and actually present to us saying why they are in that position at the hospital, what has been done, what they are going to do, how they are going to turn it around, what resources they've got to help them do it, what they need. And that might then give us more of a feel of exactly where in the organisation the problems are emanating from. So it's not a good report, and I am concerned for the future. Thanks, Mark.
Thanks, Richard. Joe?
Thank you, Chair. Richard, I absolutely do understand your concerns, and we'll most definitely reflect on your comments and suggestions. I don't agree with your assertion that there's no ownership of the challenge. I think you would expect me, quite rightly, to mildly disagree with you on that point. The fact that it's a challenge to identify savings, I don't think from that you can directly draw the inference that the requirement to achieve our statutory duty is not well understood and well owned within the organisation. I think you would expect me to say that, and it feels to me to be the case. Thank you.
I guess Richard's related observation, though, Joe, is then, if that is the case, why are so many divisions overspending, and why are so many divisions under delivering on savings? I seem to recall that when the savings arrangements were set and the targets were set, a concern was raised about the assignment of saving targets out to the divisions and whether there was an acceptance of the savings targets being allocated. And we were assured that that was the case, and the approach that being adopted this time around was different. Well, if it was, then clearly there's a concern still about whether that ownership has been accepted, because delivery doesn't not go with a sense of ownership. And I guess that's where the concern is being generated from. So I think we've well articulated the concerns on this particular subject. You've referred, Joe, to steps now being taken to recover the situation. John C., you referred to a meeting, workshop, call it what you will, with PFIG. Can I ask, John, that you turn the attention of that session to the concerns that have been articulated here, and determine the extent to which you are satisfied with the responses described, and if need be, John, then we'll have to return to this conversation through escalation to board.
Sorry, Mark, the meeting I was referring to was one that was supposed to have happened that focused on savings, not with PFIG. So I was looking for an update in terms of whether that had identified further savings, some sort of quantum of what additional savings that might have come up with. Doesn't sound like it's identified anything substantial at the moment.
So alternatively put then, John, can I ask that PFIG and you as its chair ensure that there is sufficient rigour applied to this topic at your next meeting?
Absolutely.
Particularly an assessment of the assurances being provided and whether they are starting to raise the level of confidence and assurance that you might feel you need. And if not, then that will have to be escalated for further discussion.
Okay, yeah, will do.
Okay, Joe, you happy with that?
Yes.
Thank you. Thanks. Thanks, Sue. Thanks, Joe. Thanks, everyone. So we then move on to the capital programme report. Sue.
Yeah, thank you, Chair. Just based on time, I'll take the report as read. I guess it was a request to bring an update to the board so that we had sight of the capital programme. I guess the headline numbers are that we have an allocation of 10.971 million as discretionary capital from Welsh Government. And we have 4.25 million confirmed Welsh Government funding for imaging and radiotherapy. The programme has been to PFIG for scrutiny, and what we've had to do because of the reduction in the discretionary capital programme, which is about 24% reduction from last year, is we have overcommitted schemes this year on the basis that we do anticipate slippage from Welsh Government, and we had a conversation with them 2 weeks ago where they confirmed that is highly likely and that we do have schemes obviously in place because we have got them in the capital programme to review that. The capital investment group has considered the capital investment required over the next 10 years and has done an update to Welsh Government, which I've talked about already during the board meeting, which has indicated a total requirement of about 1.6 billion over that 10-year period. And then just in terms of the capital programme, so the Health Board approved the 5-year capital programme board in March, and it is looking at a number of business cases, and there is a summary on page 4 of the report, page 5 of the report, that lists those schemes that are currently with Welsh Government. But in order to agree what went into the capital programme, we went through some prioritisation, and the criteria is listed on page 4 of the report. We also triangulated the schemes that we prioritised against the BAF and the risk register, so that's noted on page 4 and 5 of the report. And then the final thing that I would like to just point out today is the estate strategy update on page 7. So obviously we've talked about the fact that the current strategy expired and was due for a refresh in March of this year. What we have done is we have gone out for a partner through an NHS framework to get the estate strategy updated as quickly as possible. We expect to get 3 outputs from it. One is a refreshed estate strategy that talks about what we need to do and links together all the various capital projects that we've got in train. The second is a prioritised capital investment plan so that we are clear, and we've taken that through board so we understand what it is that we need to prioritise, given that we have, major issues around backlog of maintenance. And I guess Dylan in his status update on ICT will have some concerns around some of the ICT infrastructure that we have. And the final thing that we'll get is an estate rationalisation programme, which should detail what we can do to move forward the use of our accommodations, assets where we can do, and then also dispose of the assets that we no longer need. And the plan for that programme of work is that it should conclude in October, and we will have those outputs in early November. But obviously we are trying to accelerate that as much as we can to ensure that we can commit to that deadline. I would leave it there, Chair, and I'm happy to take any questions or feedback on the capital report.
Okay, and we have had a number of conversations already around estates and capital.
Yeah.
So are there any immediate questions that spring to mind? Molly?
Chair, not a question on this item. It was just a proposal when consideration's completed.
Claire? Thanks, Molly.
Thanks, Chair. I think I guess one thing that's reassuring in the report is the fact that we're proposing to use 50% of this year's budget to address some of those health and safety issues which have been identified in the risk reports and other matters. But I guess I just wanted to say, I think the report just emphasises, because we know we've got significant challenges around insufficient capital to meet our needs, the need to start to be really creative about how we take forward some of the really big priorities for the Health Board. So, but let's say positive to see a focus on some of the health and safety items. Thank you.
Thanks, Claire, and I agree. Thank you. Molly? Back to you.
Thank you, Chair. I'm just going to propose 2 quick points. So the first one was that we formally receive the PFIG Chair's report after this item, as is quite related to the last 2 items. And then the second one was just that, as we have mentioned the AGM in the finance report, I thought it'd be useful to just mention that we do have a confirmed date now, which is the 29th of September from 3:30 to 5 p.m. It's just in the public interest to make sure it's noted in the minutes as well.
Okay. In terms of the PFIG assurance report, John, there were no items listed for escalation to the board. Is there anything you wanted to highlight then, bearing in mind the conversation that's already taken place?
Most of it we've already covered. The only other thing I was going to talk about was the cost pressures and the disconnect between Welsh Government expectations on performance and what potentially we can achieve. But it's in the report. If there are people who can ask me questions afterwards if necessary, or I can take them to PFIG, but nothing to escalate.
Thanks, John. Thank you. Okay, so we'll move off the capital report. I've agreed with Sue, we'll deal with the next item after lunch because I'm conscious of the time. So I'm suggesting we have a further comfort break now. We are significantly running behind time, and we've got a hard stop at 3:30 because we've got a workshop with colleagues from the GMC and others joining us. So with that in mind, we do need to reconvene pretty promptly. So can I suggest you grab whatever it is you need by sustenance, but we aim to be back here at 22. So that gives us 20 minutes. Is that agreeable? Yeah, thank you. All right, 22 it is. Thanks so much. Okay, it's 22. Let's carry on. Sue, are you and Sally ready to proceed with the equality annual report?
Thank you. I'm just checking that Sally is on the call. Yes, she is. Fantastic. So I am going to briefly, because I know that we're short of time, just introduce the item. So this is our annual equality report. The reason that I specifically wanted to introduce it, and I specifically wanted Sally here today, is because Sally is shortly going to be leaving us, and I wanted to properly record my thanks and I am sure thanks on behalf of the board for all of the hard work that she has done. We wouldn't be in the place that we are now without Sally's leadership and excellent relationship building, excellent analysis skills, excellent leadership. So I really wanted to say that before I hand over to colleagues for any questions, which of course I would hope that Sally can answer, but if not, I can support as well. I also think I wanted to note as well, and I'm really sorry that Jackie isn't able to join us today, but Jackie's support from an independent member point of view, as well as a trade union colleague, and particularly as lead for equality, has been and continues to be invaluable. So I just wanted to note that as well. But happy to hand over to colleagues for any questions, but wanted to record my my sincere thanks to Sally for all of her hard work on getting us to where we are with equality and inclusion. Thank you.
Okay, Sally, and welcome. Is there anything you particularly want to highlight, Sally, in terms of the equality annual report, please, before I open it up to questions?
Thank you. I think very briefly, of note really, I think is the work we've managed to continue to engage with our equality stakeholders virtually over the last couple of years, and their very constructive contribution to all of our work. So we're very grateful for their input and continued support. The development of our staff networks and also the positive influence of the networks and the implementation of the social economic duty last year, I think has been key for us. So yes, thank you. I'm happy to take any questions.
Thanks, Sally. Can I open it up for observations, questions then? Okay, I'll go first then. So the work nationally around race equality, and I think this will play into a conversation that I think you and Sue may be having. Where do we stand in that regard? You know, there is national work going on, not least around board composition and the like. Are we appropriately cited on the work that's been launched nationally or has been launched nationally? And do you feel that we've got a platform, Sue and Sally, to take forward the work that is required by us to be done?
Yes, thank you. We've watched closely the development, and we've informed the development, responded to the consultation of the Race Equality Action Plan for Wales, which has now been launched as the Anti-Racist Plan. So last year we did start to do some preparation for this. We have a Race Equality Action Group that's been established to look at workforce issues specifically. Going forward, we're looking at expanding that group so that we can build in the service requirements of the Anti-Racist Plan. We're currently working through revised terms of reference. There's been a paper that's been to the People and Culture EDG, and a paper that will go to the next PPPH.
Thanks, Sally. And I think just to add, one of the developments over the last couple of months particularly has been the identification and the agreement of exec colleagues to lead and champion specific work against some of our protected characteristics. So very grateful for Gareth to be involved in the race action group. I'm involved in the disability action group. I know that Joe is in relation to gender. I think that will really help us as well as we move forward in terms of some of our work. I think it's fair to say that not unlike a number of organisations across Wales and the UK, we have a lot of work to do in terms of proper representation across all of the levels of the organisation. We've seen that with the gender pay gap. We will see that with other pay gaps, and that's something that we need to bear in mind as part of our talent and succession planning, our leadership development, and our recruitment and onboarding. So making sure that this is a theme that runs right through all of the work that we're doing is really, really important. This isn't the work of the equalities team, as we've discussed before. It is the work of us all. Thank you.
And just on the subject of race and selection, I'm attended protected characteristics and unconscious bias training next Tuesday. And I'm doing it, bearing in mind I used to run the national selection processes for the police service with a occupational psychology team supporting me in providing a whole raft of training around those topics to the assessors nationally. But there is an expectation, isn't there, for all board members to attend that training. So I'm hoping that we will be, as a group of people on this board, ensuring that we're all attending that training in our own right, because I do think it's important.
Yes, so yes, absolutely. There is a requirement for board colleagues. We are also building in, as part of our objectives for this year, building in the requirement for, and we're going to start with AACs, so consultant panels, and then run through to all recruitment and selection. There will be a requirement for colleagues who are participating in panels to have done recent and up-to-date training around value-based recruitment, as well as equality and inclusion. Recognising the volume of recruitment that we do, we want to put that in place as a mandatory requirement, but at a point that we know that is then not going to reduce our performance against recruitment, because that would be kind of shooting ourselves in the foot. So, but that is part of the objectives for this year.
Okay, thank you. Angela.
Thank you, Chair. It's a comment more than a question, really. So from Sue and Sally's point of view, having in a previous life been an equality and diversity manager and an equality lead for a large organisation, I just want to congratulate you on this report. Obviously, for an annual report to have this much content and the aspiration of what you're going to do going forward and the presentation of it, having written many of these reports and how difficult they are to put across, I just wanted to congratulate you, and I really look forward to pursuing the equality and diversity work, and I'm sure you'll be sadly missed, Sally.
Thanks, Angela. Lucy.
Thank you. First of all, on behalf of Jackie Hughes, Sally, you may be aware, of course, that she hasn't been able to join us today, but she's asked me to pass on her personal thanks to you for all the work that you've done, and she's sorry she can't join us today. I just wanted to, it's a great report and you know, really shows the accomplishments here, which, you know, credit to all the work that's been done. I just wanted to quickly pick up on the gender pay gap bit. I'm reading from the report that there is more work to do on that to understand it, given that, because as it clearly states, you know, we have got a higher proportion of women working for the organisation, but it doesn't appear that we are clear yet as to why, even with the taking into account the lower paid posts that women occupy in the health board, whether that actually is the reason for the gender pay gap identified. Have I read that correctly?
Yes, I think the gender pay gap, the reporting, is a snapshot in time. And what we're working to do with the staff network, we've recently established the Gen Network, is to complement that data and intelligence with lived experience, so we can start to look at issues around perhaps work-life balance, leadership opportunities, recruitment, retention, all those sorts of things that impact really the gender pay gap in organisations.
Okay, any idea when we'll get to the bottom of that, or is it how long's a piece of string?
Yeah, I think it's something that all health boards are looking at across Wales.
Okay, thank you very much.
Thank you. Thanks, Lucy. Linda.
Dwi'n meddwl, diolch yn fawr iawn, Cadeirydd. Dwi'n meddwl oedd hi'n deg I deud bod aelodau'r Pwyllgor Partneriaeth Cynllunio a Iechyd Gyhoeddus hefyd wedi croesawu'r adroddiad yma'n fawr iawn ac yn cydnabod yr holl waith sydd wedi mynd mewn. Ond un elfen o'n I jyst eisiau codi fo Sally, ydy'r elfen o staff yn teimlo'n digon diogel I siarad allan, achos dwi'n gwybod bod dipyn o waith wedi cael ei gwneud yn y maes yma, ond hefyd da ni yn sylweddoli bod rhai o'r staff yn teimlo bod nhw'n gorfod codi pryderon tu allan y sefydliad yn hytrach neu codi pryderon trwy'r llwybrau sydd wedi cael eu gosod. Does eisiau gofyn am sylwadau ar lle da ni arni gyda annog staff i teimlo digon diogel i siarad. Diolch.
Sorry, I'm really sorry. I've only just put my translation button on. I wasn't very prepared for that. Could you just repeat that quickly for me? Sorry.
It's fine, Sally. I'm happy to answer.
Thank you.
Okay.
I'm happy to answer because so that relates, the question was predominantly around speaking out and encouraging staff to speak out. So links very nicely into our Speak Out Safely. So clearly we launched our Speak Out Safely facility last year. We've taken our first year's report through remuneration and terms of service and PPPH committees. One of the key elements of that, and particularly one of the key elements of having the multidisciplinary team, is making sure that we are tracking themes as well as immediately responding and then learning from across all of the pieces of work that we do as an organisation. One of the things that is really interesting, and I think that we need to establish a greater connectivity between the staff networks and Speak Out Safely and the MDT. And I know Gareth has been pursuing some of this work more recently. Is some of that lived experience that's coming out through the various staff networks is really, really compelling. It's very hard to hear, but it is very compelling. And it's how do we engage our staff network colleagues in sharing their lived experience, and then using that respectfully in the organisation to then encourage colleagues who may have experienced similar things or maybe feeling in the same way to come forward so that they can be part of the wider work around Speak Out Safely as well as our equality and inclusion. It is about joining those two things up. We know that we're a year into Speak Out Safely. Whilst we are ahead of other health boards in Wales, we know that we've still got a lot to learn, and only by people's experience do we believe that confidence will continue to grow. So very much connecting the work of the staff networks with the Speak Out Safely work is absolutely key.
Okay, I've got a question to raise. It was not long ago that Joe and I received an email from a clinician from overseas who was also BAME, expressing a wish to ensure that the significant proportion of our workforce who are from overseas and who will meet one of the characteristics or more than one are sufficiently recognised and also sufficiently engaged in the work that we're doing. What's our view on that, Sally and Sue, in terms of that engagement with the considerable number of staff that we've got from underrepresented or groups with protected characteristics, and is there more that we should be doing?
Okay. Sally, do you want to answer that, and then I'll come in?
Yes, thank you. BC Unity, which is our staff network for overseas and ethnic minority staff, is really key, really, in terms of providing that opportunity for engagement, also peer support and escalating issues. And Gareth Evans, as our exec champion, will be attending that. So there's a direct link to board there, which is really helpful. Our approach in terms of developing our plan is very collaborative. So the groups that we are looking at now, we're ensuring a representative as they can be across different levels of the organisation, so that we are informed by lived experience as well as the research reports and the data.
And the only thing I would add to that is, I mean, clearly, as we have significantly increased and continue to significantly increase our recruitment overseas, it is absolutely essential that we have an environment that colleagues joining us from overseas feel is conducive to them doing a good job, B, them making a home here, and C, them being really able to contribute to how do we support that diversity across our organisation moving forward. I think the fact that we are recruiting the volumes that we are will support that as well, because a significant amount of feedback suppose probably 10 years ago when international recruitment really kind of grew across the UK, was that actually recruiting small numbers of colleagues from overseas, and then not necessarily recognising and honouring some of the cultural dynamics of that was even less helpful than not recruiting them in the first place. And a lot of organisations saw quite a high attrition rate. Our aim is to recruit well, recruit respectfully, and to retain, and for colleagues who've joined us to become ambassadors for the organisation, and that's where a lot of the work around international recruitment is absolutely pivotal. We are working together with the All Wales programme around international recruitment as well, just to make sure that we're not just going for volumes. We want to make sure that we can look after people when they come and join us. So there's a real balance to be made there. Okay, thank you. So going back to where we started, thanks to the report, and the board receives the report in regard to the comments that have already been made. Thank you both for all the work that you've done to lead this important area. And Sally, can you pass that on to your team colleagues, please, so that they are aware of how it is received and the feedback offered. Sally, I suspect we'll cross paths again, but just in case we don't, can I take this opportunity, first of all, to thank you for all the work as I've just had, but also wish you well if our paths don't cross. And thank you again for your contribution to the organisation and all that you have offered and represent in terms of equality to our patients and communities. Thank you very much.
Thank you.
Okay, thanks both. Thanks, Sally. So we'll move on to the patient safety report. Angela, is it you fielding this?
Thanks, Chair. Yes, I'm going to give the highlights, and then Matt will be able to answer any specific questions. Obviously, it only been my 4th day, he'll be able to have the detail. So from the report, we're looking at the period of April and May, and wanted to look at the nationally reported incidents. So currently in that period, we've had 20 incidents, which is down from 42 in February and March. We could very pleased to see that falls have reduced in that period, and we'll continue to do the work on falls, which my corporate team are leading on. There has been an increase in overdue incidents, but I'll come to that later in my presentation. All of the national reported incidents have had a Make It Safe review, and they've had a rapid learning panel as appropriate, and I attended my first one yesterday with Jill and found that really interesting, very thorough review of those incidents that had been occurring. From a never event perspective, you'll be aware that we had 12 never events in 21-22, and we've had 2 year to date, but in this period we haven't had any. Again, there is a theme around the length of time of investigation, which again I'll come back to. Patient safety, looking at the improvement programme that's in development, I'm going to spend some time with my corporate quality team to look at how that's progressing, what the plans are, and to see if there's any insights or support I can give to that for us to take that forward. Inquests, we've had 65 new inquests or requests for information in the period, and 54 have concluded, and as part of that we've had 3 Regulation 28 notices which we'll be reviewing and taking forward. Those are detailed in the report. And then from a complaints point of view, you'll note that we've had an increase in complaints for this period, with 417 formal complaints and 298 early resolution issues. Overdue and response rate again is something that we're looking at. So there is a theme around overdue incidents or response rates that we need to be addressing. I've already discussed it with Matt and the quality team, pulling some information out of the position we're in, and at the accountability meetings that we're having with the divisions next week, we're going to be presenting the positions and asking for trajectories going forward to reduce those and get to a 0 position in the future. We'll present that back at the next board meeting, showing where the actual delays are and what we're doing from a corporate response to help those divisions, bearing in mind the amount of pressure that's on there at the moment. I'm sure Matt is happy to take any questions, or I will if I can answer them, Mark.
Thanks, Angela. Any questions, please? Lucy.
Thanks for that, and welcome, Angela, to the Health Board. So, I mean, I won't go over in too much detail, conscious of the time, about the comments that I made at the beginning, earlier on in this meeting, about the fact that we still don't seem to be able to demonstrate evidence of learning from incidents. And as I referred to before, we've requested then as a committee that we start looking at near misses in more detail and have some assurance that they are being addressed appropriately. The never event learning continues to concern me, and we absolutely need to strengthen our reporting on this in order to provide the assurance that it is actually being monitored. And I also just wanted to bring to the board's attention that in terms of the Regulation 28, we have a report coming to the next QSE committee following concerns raised about the lack of assurance over learning and implementing and embedding the learning from Regulation 28 over the past few years. That will be the public section of the next QSE committee. And we have acknowledged that at this present point in time, we do not have assurance over the implementation of the Regulation 28s. That's not to say they haven't been done, but we don't have any assurance over it. Thank you.
Thanks, Lucy. I have been updated on that report that's going to be coming. I'm going to be meeting my team, as I say, for day 4, so those meetings are going in, and we'll be looking at how we're going to be monitoring Regulation 28, the never event progress, etc., and having a centralised way of doing that, and then a more effective reporting to give you assurance at QSE.
Thanks, Angela. Thanks, Lucy. Cheryl.
Thank you very much, Chair, and welcome to Angela. Just 2 quick points. On page 8, we talk about the ward-based, the care actions on deterioration document. Hopefully Matt can tell me whether that has been completed. It was due to be completed end of July, and how the effectiveness of this is going to be audited. That was the first one. And the second one on page 18 was the response with the coroner by the 1st of July. Thank you very much.
Hi, Cheryl. Yes, I can confirm that was implemented, and there's a rolling programme of audits. And I can also say that the first audit results actually came into my inbox today, but I haven't had the chance to look at that in detail yet. But just to reassure you that documentation has been implemented, and there is a monthly rolling audit programme. I'd be happy to share the results of that at perhaps next QSE once we've had a chance to review it. So hopefully that answers those questions, Cheryl.
Thank you, Matt.
And sorry, the second point about the Reg 28, yes, again, just to reassure you, all of the responses which were due at the time this report was originally written, the 2 responses, they have been sent through to the coroner on time.
Thanks, Matt. John.
Yep. Thanks, Angela. Yep. Thanks, Angela, for the report on this. Just 2 specific points, if I may. One is in relation to clinical negligence and the reference to 85 particular cases during the bi-monthly period. In terms of the steps taken afterwards, and it's possibly something to pursue as well, what actually happens to the relevant people who have been involved with clinical negligence? Is there particular action taken? Is there particular retraining? We don't seem to hear what happens to the staff who are involved in clinical negligence cases. So that would be the one point. And the other point, I noted you did say about the various delays, but we do hear or read in coroner's reports quite often over the delay in information being provided from the board to inquests. So I presume that is something that you will be taking on board as well. Thank you.
Thank you, John. From a clinical negligence perspective, I think probably Sue could provide us with a little bit more of an update on that one. Obviously, there's different processes that happen, and as standard across organisations in the NHS, we do support staff identify whether it's about retraining, looking at capability and things like that. But I'm obviously new to the board, so Sue will be able to give that more information. From the second point, sorry, could you just remind me what the second point was?
Yeah, it's just really in relation to the time factor again about dealing with requests for information, both for the coroner and ombudsman. There's been a lot of criticism in the last few months over the delays to provide relevant information. Quite often, staff have actually left that were related to the original case.
Right. Yeah, thank you. So in previous roles in organisations, obviously this does occur, that the delays happen. So I think what we're going to be doing with the quality team and with Matt and colleagues is looking at prioritisation, looking at those coroners, ombudsman cases, etc., and making sure that we've got good processes in place. I think the monitoring and from the accountability meetings that we're going to be having, speaking to the teams and doing the chasing of the teams to get those responses, and providing some corporate support from a my nursing team point of view to give that extra support into the divisions will give us that opportunity to get back on track where we need to be.
Thanks.
Thanks, Angela. Sue, then Matt.
Okay, thank you. So I suppose one of the things I was thinking of how to answer the question, and I think the best thing for me to do is to start with the fact that as an organisation we have committed to trying to create an environment that is a just and learning culture. And Lucy talked earlier on around really using near misses to understand what can be done to improve safety of services, etc. So, and that does require us, really does require us to have that just and learning culture. Now, clearly, when I'm saying just and learning culture, it doesn't mean that, as has been interpreted previously, that means what we only ever do is look at retraining, we look at support, we look at kind of what has been described to me previously as being a bit softer. Clearly, at the point of the incident, if there is any evidence to suggest there has been a conduct issue, then that is progressed through the appropriate procedures and may and has had an impact on individuals' employment. But we very much use the principle of the patient safety incident decision tree. So really looking at the point of the incident. So by the time a clinical negligence claim comes through, often that's years down the line. We do look at it at the point of incident, identify whether there is any willful conduct issues, or whether actually what has been described is more systematic, as well as whether there is an individual capability issue. I've picked up quite a few times over the last few meetings, both board and committees, that is a question that is often asked. And I think what would be helpful is if Angela, colleagues, and I can work together and think, well, okay, so how do we provide that visibility and therefore provide a level of assurance that it's not just that, you know, we're focusing on the process and missing the point. So if we can think about how we could provide that assurance in a meaningful way, and then perhaps link with yourself, John, and Lucy of chair of QSE to agree how we might do that.
Thanks.
Thanks, Sue. Right, Matthew, can you be brief? Then I'm going to have to close this item down, please.
Yes, sorry, Chair. I'll be very, very brief, just to offer some further assurance, if I may. So for every claim, John, we produce what's called a learning from events report, which itemises all of the learning and the actions, and we have to collate the evidence. And that, in addition to being approved through our management structure, also is submitted to the Welsh Risk Pool, where it's assessed by Welsh Risk Pool Safety and Learning staff, a national panel, and then also the Welsh Risk Pool Committee. So there are processes, and that process does force us to capture clearly the learning and collect the evidence for liability and clinical negligence claims. I'm certainly happy, as Sue said, to discuss how we can maybe strengthen the reporting on that. And just on the inquest and the ombudsman, the biggest challenge we have at the moment is delays around getting investigations completed in a timely manner, which Angela's alluded to. But to support that, in addition to everything Angela said, there's also a monthly meeting with Dr. Lyons to review the upcoming inquest and ombudsman, and to look at any barriers that we have so we can tackle those. And that's a process that's only just started in the last month or so. So I think that will help provide some greater executive oversight and drive behind that.
Thanks, Matt. Okay, Angela, can I, this report is developing and in the right direction. You've already referred to further work to be done. Can I ask that you liaise with Lucy in that regard as chair of QSE to ensure that the developments meet your expectations and hers on behalf of QSE and the board, please?
That's absolutely fine.
I had a number of questions, but I'm conscious of time, so I'll not pose my questions. What I would ask is, and it appears in some places, but not in others, where we have identified a shortcoming in a report, Angela and Matt, and we then identified the fact that we are pursuing a range of actions. My immediate question becomes, well, when are they going to be completed? Can we give a greater sense for that in future reports, please? Because it will help us gauge how quickly the improvements are going to occur and what effect they're likely to have and when. Yeah,
make sure that happens.
Thank you.
Thanks.
Thanks very much for the report, and thanks for the questions that have been posed and the responses. So, you know, again, I'm conscious of the time. We've got 19 minutes until we're due into the workshop. We might have to come up with a plan B once we close the business for this public meeting. But with that in mind, Nick, Vascular is the next report.
Thank you, Chair. So very briefly, before I focus our minds on recent events, if I could just remind the board that following the introduction of the hub and spoke model in April 2019, the board commissioned a invited service review from the College of Surgeons that led to the vascular improvement plan being produced in response to part 1 of that report. And that report, Chair, is continually reviewed at the QSE committee on a regular basis. The second part of the college review that reported earlier this year in February recommended further detailed review of the notes that the college had considered. This led to the vascular quality panel being set up with an independent chair. That report, the panel reports regularly, and those reports inform a vascular improvement plan. But by exception, an escalation from the panel was received on the 8th of July. And as detailed in the report that you have read, that recommended the recommencement of dual consultant operating for all patients having aortic surgery, and that our MDT, our decision-making body around aortic surgery, should be supported by an external body. That's very similar to, but slightly a nuanced version of some make-safes that we had put in place earlier this year and subsequently lifted. As a result of this, dual consultant operating means, sadly, that other procedures have been delayed, and I would want to apologise to patients who have been affected by this. But as always, the safety of our service remains our paramount concern. Board members will also have been aware of a statement that was made after this report was written, made by the Minister for Health and Social Services on Tuesday of this week, that I believe rightly we strengthened our contingency planning were the fragility of our service due to our consultant and nurse numbers, but also made worse by our dual consultant operating requirements. That has, although the right thing to do, has led to some greater fragility and greater pressure on our on-call arrangements. Thus, as the Minister outlined in her written statement, as well as looking to Liverpool for support for our vascular service, our contingency plans now include the possibility that we would look to Stoke, with whom, of course, we already have a relationship on our trauma network for potential support for our services, should that be needed. I'm pleased to report that that hasn't been needed thus far. Very happy to take any questions, Chair, but I hope this report shows, as I said, our ongoing priority and focus on safety for our patients.
Thanks, Nick. Observations, questions, please, from colleagues. John G. John?
Thanks, Nick. Yeah, just to unpack a little bit with regard to the aortic situation and obviously the shortage of consultants that we have at the moment to provide 24/7. But more precisely, do we actually now have a position where we're actually sending patients to Liverpool or Stoke for elective surgery? Or is it still purely emergency that we're actually dealing with going out of county? So it's just to identify what are we actually still doing in YGC if we don't have the capacity to run a 24/7 dual service.
Thank you. Thank you, John. So our dual consultant operating is for both emergency and for elective aortic surgery. And our contingency plans are there for both out of hours emergency and elective surgery. But thus far, since the 8th of July, no patients have had to leave the health board as a result of these extra make safes. I would just, for the absolute clarity, say that occasionally very complex patients always have and always will go to Liverpool for extremely specialised services. That's not associated with these make safes, and those patients continue to go to Liverpool.
Could I just come back on one slight point, Chair? In the point of if somebody is being sent to one of the other hospitals, do they still need to come via our own ED departments to be sent, or can ambulances be rerouted on their way in and dealt with by paramedics?
Both possibilities.
Point of view for the patient's perspective.
Thank you, John. If I may answer, Chair, both possibilities are being considered within our contingency planning, John. Our current arrangements with Liverpool do expect patients to come to the hub, Ysbyty Llanllwyd, in the first place before moving on to the Royal Liverpool. However, we are considering the possibility that should it be necessary, because our service wasn't able to deliver aortic surgery for a longer period of time, the potential that patients could travel straight to the Royal Stoke.
Thanks, John. Does that satisfy your question?
Yes, thanks, Chair. Thanks, Nick.
Thanks, Nick. Lucy?
Thank you very much. So I've met with the chair of the vascular quality panel on a regular basis. So, you know, she's kept me well cited on the work that they're doing, very thorough review that they're doing, and he is appropriately escalating concerns to you, Nick, as you've referred to. And you and I have spoken about this as well. This is, I think we've really got to be realistic. We've got to start being realistic now about this service, making sure that we are doing the right thing for our patients here. And there may be some difficult decisions that need to be made. Again, you and I have talked about that, and I know, you know, you are on the same page with that regard. And I just think it would be helpful to just confirm, though, as well, that we, as part of these arrangements, we need to make sure that we do not drop any quality standards at all in terms of, you know, recruiting any additional vascular surgeons or the clinical director, et cetera, because whatever make safes we now put in place on a more permanent basis, everyone has got to feel confident that those make safes are going to do what we need them to do, whether that is in whichever way that needs to be delivered.
Thank you, Lucy. And again, safety and quality of our service has to be our priority. Therefore, we have to, and we are focusing on a number of potential possibilities and scenarios to ensure that we can offer that continuity of service. That said, I think we have taken expert advice, and I strongly agree with that expert advice that the network model that we currently operate in North Wales is the right model, but it can only be operated if we have sufficient numbers of staff to operate it safely.
Yes, and I think that's the point, isn't it?
In that regard, Nick, I think we are due to hold a selection recruitment panel on the in 2 weeks' time for a clinical director for Vascular. Is that right?
Indeed, we are, Chair.
Okay. And can we also agree, given the level of concern that exists around this particular service and where we find ourselves, particularly as a staffing, Nick, that you'll keep us informed, and if there's any need to escalate, you'll do so? Oh. Yeah, that was a nod, I think.
Oh, sorry, I was on mute. Indeed, Chair, of course.
Thank you. Okay, so we have got a final item now. Thanks, Nick. on communication and engagement activity, which I requested. Helen is not here, so I suggest we take this as for information only and as read. And if colleagues have got any comments about the report or the nature of the communication and engagement activity taking place, that you email Helen and copy me in, please. Is that okay with everyone? Yeah. Okay, right. So I'm now going to close the public business of the board, and we're now going to move into private session once the live streaming has been concluded. And those remaining items on the agenda that I will pick up with Molly as needed, and you'll see that the summary of private board business for publication assurance purposes is already provided at 9.3. So without further ado, I propose to close the public meeting.